some history, son wants to give some history, and it becomes difficult in video consultation when you are dealing with one person. So it's just like Zoom, 4 people are there in the same integrated platform, just click of a button and it's done. PDF lab values we can upload from our end. All these data is, as Rakesh sir was beautifully telling you, all this data comes in, the gist is prepared, the summary of lab reports is done in the prescription, just on a click. If I want to publish it, print it, it is done, otherwise it is not. This is my prescription. This is how it looks like. The biggest point is, you see the red at the last. We have incorporated this 2 years back. This is a patient verification record, the moment where the PDF was generated. You see a MI in the morning, the patient dies in the evening, he is roaming around, and the date is same. How you will deal with this? So the moment the PDF is generated, the timestamp is created. It's not my responsibility if I have written, get admitted within 30 minutes. After 30 minutes, I am not legally liable for any mishap which is happening to my patient due to that. Moving further, this is how it looks. We can send WhatsApp, and that is how we have created our clinic literally paper-free. We first ask patient, we have tagged patient, they don't need paper prescription. There are 10-12% of patients, we don't need paper prescription at all. They are happy sending it to WhatsApp. On click of a button, it is sent to the patient and 2 other family members which are there with them associated. Benefits are many. Unified patient record, we all know. Real-time updates we get, decision support tools, efficiency gains, and many other. Now, the biggest thing which it gives me is to participate in research, because I have hefty load of data with me which I can use in the way I want just after taking patient consent. Mind it, you need to take consent of patient, and then you can have the data analyzed, and you can be more scientific, you can know the trends, you can have your own data to publish at lot of places. Not telemedicine, Rakesh sir was telling about this, and it actually expands the quality of service and reach of service. This is need of the hour, because as I was discussing with Vijay sir also, many patients find it difficult to reach from far away places. So first consultation at our place is physical, second is digital, third we prefer physical again, but if it doesn't come, then digital. So it actually increases our revenue, better connect, the patient feels more connected to us rather than going to a doctor which is nearby. He is connected to us for the day-to-day needs also. Patient education we also incorporate through all these mediums, because we conduct Zoom sessions and all those things. And this is very easy to do once you have all the data with you. Remote monitoring is also very easy to do, because patients feed in their data, as I have told you, and we have their data with us. Scheduling and follow-up, which is a very, very big hurdle, becomes easy once we incorporate this into our system. Now, impact of telemedicine. We did this, we actually submitted our abstract there in the endocrine abstracts. It was published in European Society of Endocrinology. We saw the impact of telemedicine in patients, those who are not able to access the care, and the results were phenomenal. The patients were liking it like anything. It again does one more thing. It enhances the patient engagement, because through patient portals, we actually implemented the patient portal, one which opens at the patient end. It provides secure access to health record, lab result, appointment scheduling, because if he goes to some other doctor, he has all the data with him on a click of a button in his portal himself. Mobile app is there, which gives daily notification, daily reminder to patient, motivational quote, some health tip, whatever, just to increase the patient engagement. Educational resources are given. We have generated QR codes for that. We circulate it to the patient electronically only, and they just watch the videos, fill in the forms, solve the quizzes, and all these things. Feedback mechanisms become very easy. It is a tough thing, because patient seldom says something at your clinic. So we can take feedback about our staff, services, and ways to improve, what are the ways to improve. This is actually WhatsApp system which we have at our clinic. This is again a support group system. We have a connected care system. So some patients who require frequent monitoring, we put on this. And this is again a generative AI based system, where the system is prompting, the patient is giving responses, and at the end the summary is prepared, and I just need to read the summary, nothing else, not the whole text, and it is presented to me, and then I can suggest some ways and or call the patient to my clinic. Data analytics can be leveraged with all these digitalization, because we have data collection, we can do predictive analysis as well. We can do the population health management. We can improve the quality of system and quality of care as well with this. Now, we can do the clinical decision support system also. We can implement it because we can send real-time alerts to patient. We can integrate guidelines into system so that we are prompted once creatinine is high, we are prompted not to prescribe certain medicine because it calculates eGFR as soon as I put the creatinine value and click the save button, the eGFR is automatically calculated. Risk stratification can be done, and personalized treatment plan, as Rakesh sir was telling regarding diet also, can be prepared with the help of this system. We can track the patient metrics, how good we are doing, because ultimately what we are doing is for our bread and butter, and we can calculate what the metrics are. We can track individual and group of patient, how the patient group is behaving, what are the new trends, what is the actually going on with the patient, what are the type of patients coming to our clinic. But there are certain challenges also. Challenges were first resistance to change. From myself, from my staff also, we had this change, resistance to change. Initial costs were a little burden because we need to purchase somewhere around 6-7 laptops, printers and other things. Data privacy concern, because we all know we talk about these things. Data privacy is a major concern as far as data regarding the health is concerned, because everyone, and we cannot trust the intention of vendors also. So our software which we use at our clinic is ISO 27001 HIPAA compliant, and actually there are cases I have told you, interoperability issues were there initially, but we learned from it and we developed some solutions. So solutions were to overcome challenges. We developed continuous training and support for our staff, even though we are not doing anything. Every 2 months our staff has a training session for 2 hours, because something new here or there comes up. Phased implementation, never go full, gradually increase your digitalization, because once you go fully digitalized, it will become difficult from a person who is not. Multi-factor authentication, because it is required, and regular security audit to protect the patient data, because patient data, if it is lost, it's your liability. Collaboration is the key. We work closely with our technology vendors. We in fact give them a weekly report. We ask them weekly to implement one or other thing, and that is how we have gradually evolved and come up to here. This ideally should be the ecosystem, and collaboration is the key. The doctor mobile app should be there, doctor should be there, patient app should be there, and everything should be integrated. This is how we measure success, by key metrics, regular review, patient feedback, and staff feedback. This is all the things which we have presented. This is in ADA, where we use the mobile messaging for follow-up and glycemic control. Again in ATTD, we did it at Endocrine Society via WhatsApp messaging. We improved the patient compliance. Impact of WhatsApp on glycemic control and exercise habits, and patients who were achieving HbA1c gold and depression scores were going down in those patients. Effect of WhatsApp again on intervention on insulin adherence and treatment effectiveness. This is all our data which we did from our center and presented it. Moving forward, these are the case studies. I will not take your time for this. The financial perspective, the last thing. Balancing cost with long-term benefit should be the key. Initial investment is definitely there, but there are operational savings, revenue generation, and long-term benefits. Future, as Rakesh sir has told, AI, wearable technology, patient-centered innovation, data-driven decisions, and that should be there. These are the lessons we learned. This is, in short, what we did in past 12 years. We started with clear objective, be patient and persistent, and which we were adaptable. That is why we were able to reach here. So I still believe the most underutilized resource in all of healthcare is the patient. Thank you.
Thank you. Thank you, Dr. Sabal. We'll take up questions towards the end of this session.
Thank you, sir.
Thank you for trying to finish your talk in time. You were almost at it. Let me next invite Professor Abhay, a good friend of mine. He is a professor and a senior consultant in the Department of Endocrinology and Metabolism, Apollo Hospitals, Bhubaneswar. He has organized many conferences, invited as guest facility. He is the recipient of Rajdhani Gaurav Award of ODISHA in 2016. He has a lot of paper presentations, posters, and he has written many chapters in different books. Welcome, Abhay, and your time starts now. You will be speaking on monitoring by continuous glucose monitoring. Thank you.
respected chairpersons, my dear friends and colleagues. So after two beautiful talk about digitalization and how we are going to see our patients or monitor our patients digitally. So I am going to discuss the continuous glucose monitoring in our for next few minutes. So if you see the glucose testing, if you see it is in 1500s, that is, it was just see the ants in urine, what is just, it was like that, how we are going to testing glucose at that time. And if you see, there is in 1700, there is water testers. In 1800, we start first chemical test to detect sugar came. And bending test came in 1915 and 1941. There are other tests, quantitative test came. So this is the how we evolved about the testing of the blood glucose. But now we have come into an era where we have actually a lot of machines, a lot of actually monitoring machines which we can monitor, we can see the blood glucose monitoring. So we have actually the amount of blood testing, the amount is very less. You have within a fraction of seconds, you can get the blood glucose report. And of course, now we have also, there is, we can monitoring and you can see the blood glucose, you can continuously monitor for around 14 days, up to 90 days, up to 180 days, we have monitorings. So if you see the glycemic monitoring, that is objective is that we have actually good glycemic control should be there, there should be clear-cut targets, there should be precise and accurate, it should be properly standardized, they correlate with different complications and mortality, they should be accessible to the patient, and it should be cost effective, and the most important thing is there should be if there are some subgroups where we can see or we can monitor, or we can actually in the special categories whether we can use that or not, that is also most important for monitoring the blood glucose. So, and again, most importantly, it should be evidence-based, and also that should be recommended by the guidelines for actually doing that monitoring. So, if you see the HbA1c, it represents, of course, we know that long-term blood glucose monitoring, and when we are seeing HbA1c, the 50% of HbA1c data is for the last 30 days, 40% is around last 30 days to 60 days, and only 10% is for last 90 days to 120 days. So what we are getting, it is a data of last 3 to 4 months, but it is the data is coming like that in HbA1c. And this is the basic difference or basic problem with HbA1c. You see there are two people, two person, you see there is a wide fluctuation of blood glucose, and the lower person having actually blood glucose is well controlled, the glycemic variation is less, but still both have same HbA1c. So if we are seeing HbA1c, probably we are missing the patients, probably we are not giving justice to the patient, because even if in this patient there is a lot of hyper and there is lot of hypos, but still HbA1c is same like this person who's actually the glycemic variability is less. So there are actually, this is the reason why actually this self-monitoring blood glucose or CGMS plays a critical role for particularly this group. So that could be the different types of machines are there which can actually show us, we can give us. We know there is self-monitoring by glucometer. We can have freestyle Libre. We can have actually freestyle navigating systems. They can actually give us good ideas. So if we see the basic parameters, what is the SMBG, then traditional CGM and also flash CGMS. Usually the fluid tested in SMBG is actually the blood, whereas in the CGMS and flash CGMS both are using the interstitial fluids. If you see the calibration, actually traditional CGMS requires twice calibration, whereas both SMBG and flash monitoring, they don't require any calibration. And duration, actually flash is for 14 days, whereas SMBG, it's not applicable anytime you can do, and for traditional CGMS, it's all 7 days. And number of tests, it is limited, whereas in traditional and flash, you can do virtually any time, unlimited times of you can do. And report interpretation, again, this is requires a software for actually traditional CGMS or flash CGMS, and training is a bit complex if you are using this CGMS system. So again, there is actually different types of CGMS, real-time CGMS is there, then there is actually professional CGMS, there are different types of CGMS, but the basic aim is actually to see the blood glucose level at actually real time and to see the blood glucose level of the patient. So normally you can do monitoring, you can do at breakfast, you can do at lunch, in between, at any point of time of the day, you can do SMBG. Similarly, CGMS also can do the CGMS, there is a machine, you can see the blood glucose report from that, we will show how you are going to see that. So there are different types of actually available machines are there in India. This is Medtronic, Dexcom, Metronic Guardian Connect and Abbott Libre Pro. These are the certain machines are there in India. And if we'll compare all those machines, then probably these are actually all are real-time, of course, is there, but number of days here actually Libre is for 14 days, whereas rest are between 5 to 7 days. And of course, Dexcom is 7 to 10 days. Everybody requires calibration except the Libre. And the reading frequency is actually all, they take a mid-reading at every 5 minutes, whereas for Libre it takes around 15 minutes. And insertion is for Libre in the arm, rest in the abdomen. And remote monitoring is, of course, is there with particularly Dexcom and Guardian, whereas remote monitoring is not required in both the things. This is the Eversense, this is a long-acting, actually living for a quite long period, because you will see it can be implanted, and this CGMS gives up to 90 days in US approved, whereas in Europe it is up to 180 days, it is approved. So this is actually the sensor is inserted under the skin by procedure and can be performed at every quarterly appointment, and also this is actually can give up to 180 days. So basic how whether you can use actually, if you see the studies of real-time RTGS or CGMS, if you see both type 1 and type 2 diabetes can be done, a lot of studies are there. The basic advantage of doing this CGMS is that they reduce the time of spending in hypoglycemia. That is the most important thing. If you are monitoring frequently, you can reduce the time in hypoglycemia. They can reduce decay. Also, they can give some sort of much more satisfaction to the patient in comparison to those who are not monitoring. So again, if you are monitoring, that you are getting the advantage, but in type 2 diabetes, you might not get that much benefit, but still you are getting benefit, and still it has been found that those who are having CGMS, their blood glucose control is far, far better and superior, and HbA1c's control is better in comparison to those who are not doing this CGMS. You have actually a lot of all guidelines has actually endorsed use of CGMS in patients. You will see this is S guideline that you can use HbA1c in the semi-annually, but for insulin, those who are on insulin, CGMS or SMPG can be done. In type 1 diabetes, it's absolutely necessary and should be done. In type 2 diabetes, those who are on insulin, those who are high risk for hypoglycemia or hypoglycemic unawareness, they can be used. But our own RSSDI guideline, which is clearly showing that the clinical situations that may require this, those having history of severe hypoglycemia or hypoglycemic unawareness, pregnancy, infant and child who are actually receiving insulin therapy, patient at risk of hypoglycemia, and there are certain groups, even if on OHA they reach CGMS, that is what I have shown, that those who are receiving sulfonylurea, organoids or insulin secretagogues, but having a irregular diet pattern, having a irregular schedule of food pattern, those who are doing very vigorous exercise, they are traveling different time zones, these are the group they need, even if they need CGMS, even if they are on OHS. There are a lot of things, a lot of ways how actually they gives. We have actually the ADDR or AGP, then there are coefficient of variations, MAGE, mode, SD, these are the different ways how actually this CGMS, watts or this CGMS actually gives us the data. You can actually from that, you can calculate the coefficient of variation, or you can calculate what is the glycemic fluctuation or glycemic variability from different methods. So this is one, the time in range is actually most easily acceptable thing what classically is actually discussed, or nowadays we are discussing. TIR is actual target is usually between 70 to 180, and the most important thing is if you are achieving more than 70% TIR, probably your HbA1c will remain below 7%. Every 10% increase in TIR, the HbA1c reduces by around 0.5%, and the target goal is around, as I have discussed, at least for 70% for particularly the TIR for particularly this CGMS. This is the IDF again 22 guideline that also endorsed that there's, if you are going for TIR, at least more than 70% time should be at least TIR, and a stricter target is required if may be emphasized up to a fasting between 70 to 140, not 180 what actually TIR is classically showing. So this is the individualized CGMS matrix was classically for type 1 and type 2 diabetes. You see the target hypoglycemia should be less than 5%, and time we are remaining in the normal range or green zone is more than 70%. But if you are going for pregnancy, probably you have to be little bit much more stricter for particularly gestational diabetes. The time in range should be at least around more than 90% or close to 90% for pregnancy. And same for type 1 diabetes. around 70%. So the pregnancy group is actually, they need a TIR of around up to 70 to 90% in particularly that. Again, the standardization of CGMS done from the MAD, that this is the accuracy remark. At least for CGMS, the MAD should be less than 10%. This is the data from actually for freestyle Libro and real-time CGMS, which has clearly shown Guardian 3 is actually showing MAD of 10.64, but otherwise all other Free Libre, Dexcom, all are having a MAD of less than 10%. So it is actually showing this is the standardization what particularly classically done for CGMS. So the international consensus report for, if you will see the CGMS and TIR, there should be a purpose for the report. There should be what shows that the report provides the guideline and recommendations to the clinicians how they are going to use. The previous updates are showing again they have certain publications, they have taken certain data and they analyze that and they have actually reached that this is the TIR should be reached at least 70%. So they have actually taken all previous data, and also they have actually clinical updates in 2019. This is the ATDT, they have given CGMS data or targets for particularly managing those. So this is the normally what classically we discuss that up to 70 to 180 is the target. If going above 180, it is called TAR, time above range. So this is against grade 1, grade 2. That means if it is up to 250, it is level 1. More than 250 is considered level 2. Similarly, if it is going below, it is time below range TBR, which actually level 1 is actually between up to 70 to 54 is level 1 and below 54 is considered as level 2 for particularly this. So again, this is the same thing. Actually, this is the AGP report. Classically, what was showing this is the range. That is the single-page glucose reports that will show a graph, and that graph will give us the clear-cut idea how many times or when the patient is actually increasing the blood glucose, when the patient is having a decrease in blood glucose. That will show. The most important part is now we have ample of data which clearly shows or clearly discusses or clearly shows actually there is a correlation with complications. This is the thing in particularly TIR with microvascular complications, which has clearly shown for every 10% less in TIR, the retinopathy progression is increased by almost 64%, and also microalbuminuria is increased by almost 40%. So there is a direct correlation. If your blood glucose is increasing, your time in range is actually reduced, then probably the risk of complication is again directly proportional or directly increasing. So again, this is between type 1 and type 2 diabetes, but with different complications. They have taken TIR of 58%, 70% and 80%. You see different complications. At TIR 58%, if you compare with 70% and 80%, definitely it is less. For type 1 and type 2, here they have taken microbial infection, end-stage kidney disease, vision loss, and also amputation. All are having actually direct correlation with particularly TIR and showing significant improvement if you are improving the TIR. This is close to 34 publications which has tried to see TIR and glycemic variabilities in comparison to microvascular complications, which has clearly shown that only TIR, not glycemic variability matrix, is associated with particularly the CV events and also cardiovascular mortality. So this is a picture what I was telling about the AGP, that if this is the picture where we'll give a graphical or a visual presentation where blood glucose is increasing or the blood glucose is decreasing, and that will actually give a clear-cut idea where should act or when should I actually change my medication, or when I should add my medication, or when I should reduce my medication. So this is that, again, this is from that trend. You can actually now you are having, there is trend arrow, which from that you can actually calculate the insulin dose. That is the important thing, that if it is, this is the neutral, that no adjustment is required. If the arrow is actually tilted upward, it is 2.5 unit increase, and straight it is 3.5 unit increase. Whereas the lower, if it tilted arrow, it is minus 2.5, and it is straight, it is minus 3.5 reduction. So again, that will give a patient idea to the patient, that from that also patient can modify the insulin dose, and that will give a personalized or personalized approach or personalized thing to the patient, or patient can take a decision by himself or herself from that. Again, this is the advances. There are a lot of advances with particularly CGMS has come. Now we have a lot of apps which can actually directly see the blood glucose level. You can see in the app in the mobile phone, and that will give us, these are the different apps, and that will give us actually clear-cut connections. If you see that if you are using an app and if you are using this CGMS monitoring, and here actually this is a performance of a glucose meter with a built-in automated bolus calculator versus manual bolus calculation. So they have taken 206 patients where actually they try to say half of the patient were given idea how they will calculate their bolus from the blood glucose level, and half will given a machine where the machine will decide the dose. What they found, if you are calculating manually, probably 60%, 3% are doing actually wrong or erroneous results, whereas those giving the bolus from the machine, there is only 6% error there. So that means that accuracy of dosing will be better with particularly that in comparison to that. So this smartphone, we have a lot of different types of things are coming. This smartphone based technology, that type 1 diabetes, it can reduce HbA1c, they can improve quality of life. In type 2 diabetes, there is not significant differences found in particularly that. So if you see the comparison cost-wise, of course, it is a bit costly, and also patient has to, in actually India, those things which are actually patient has to pay from the pocket. So of course, it is a bit costly, and this is the cost analysis, which is again from the shows clearly showing that the cost is actually this, whether it is a plus, whether it is a AGP, everything actually a bit costly in comparison to the what actually we are doing from the glucometer part. So of course, as I have from the beginning, as I have clearly shown, we have actually achieved from the glycemic monitoring, we have achieved all those targets, what I have actually clearly shown that. Just few 1, 2 slides about CGMS in the pregnancy. If you will see that if you are doing a CGMS in the 2nd and 3rd trimester, probably there is decreased risk of large for gestational body, macrosomia, shoulder dystocia, neonatal hypoglycemia, and NICU admission is significantly reduced. And this is the ADA guideline that pregnancy is one of the indicators should be done actually CGMS. But the most important part is a lot of the time whether this is applicable to the inpatients, probably no. The reason is there is extensive skin infections, hypoperfusion, hypovolemia. There are certain medications which can interfere, so probably this is not ideal for particularly use in the indoor settings. But still there are certain drawbacks, like there is a lag time between the blood glucose with interstitial fluid. There is actually some machines that did not give accurate results, short sensor time, there are sensor site infections, there is certain interference, certain drugs like acetaminophen, ascorbate. There is inadequate diabetes program also. If there is inadequate diabetes program, that will hamper that. Again, cost, as I have already discussed, cost is another factor which actually clearly implements that. So we have lot of methods. There is non-invasive methods, minimal invasive methods, and invasive methods which can give just 30 seconds. Minimal invasive methods which can give idea about particularly or give different types of glucose monitoring. We have now actually lot of spectroscopies and spectrum methods which can actually give us idea, can give blood glucose testing, and from that, these are the certain non-invasive methods. You can see from the tear, there is soft contact lens which can give blood glucose. There is actually from the saliva glucose monitoring strips, from the sweat, these are the certain, also there is watch, they also can give blood glucose monitoring from that. So again, it has found to be much more reproducible and found to be correlating with the actual blood glucose level. So summarizing my topic, that glycemic monitoring, long-term control, short-term fluctuation is of course that is being taken care by that. Type 2 diabetes, type 1 diabetes, type 2 diabetes on insulin, risk of patient having a risk of hypoglycemia, of course CGMS is best. Flash CGMS is found to be cheaper, and it is one of, there are a lot of non-invasive methods are coming which will definitely help our patients for particularly monitoring of the blood glucose level. Thank you.
Thank you, Professor Abhay. We are running behind schedule, so questions, if any, will be taken up directly by the speaker at the floor of the House after this session ends. We will now proceed to the memento distribution section for giving away the mementos. Thank you very much for a patient hearing. The next session will start now.
Thank you, speakers and chairpersons. I request you to kindly proceed to the memento presentation podium. Next, we have the incretin insulin symposium. For that, I would like to invite the moderator, Professor Dr. Jayant Kumar Panda. He is Professor and ex-HOD, Department of Medicine at SCV Medical College, Cuttack. And the chairpersons, Dr. Prakash Chandra Patra, Senior Consultant Diabetologist, Barampur, Dr. R.N. Kar, Senior Consultant Medicine, Bhubaneswar, and Professor Uma Shankar Mishra, Professor, Department of Medicine, Sri Jagannath Medical College and Hospital, Puri.
Welcome, sir. So, good afternoon. After a sumptuous launch, it's very difficult to concentrate academically, but the BB Tripathi Symposium with latest in the artificial intelligence must have activated you all. Without any delay, we'll go. We're running late, so without any delay, we'll come. And as you know, the newsmaker in insulin incretin segment is semaglutide. We have newer insulins, we have oral GLP-1, and we have topics which are relevant in present day. So we'll take a quick session, and I invite Professor Sambit Das and Dr. Ipsita Mishra for the first session. Actually, we have 3 parts of the session. The first one is exploring novel horizons, navigating the cardiometabolic trinity in type 2 diabetes, a duologue. So you can take this. Yeah, Ipsita, you can take.
So, we'll start, sir. Yeah.
Professor Sambit Das is the HOD Department of Endocrinology, IMS SHAM, and Ipsita is Associate Professor in Endocrinology at IMS SHAM. So I present both of them for the topic Exploring Novel Horizons, Navigating the Cardiometabolic Trinity in Type 2 Diabetes, duologue. Over to you.
Thank you, sir. A very good afternoon, one and all. And the topic is navigating the cardiometabolic trinity in type 2 diabetes with oral semaglutide, a duologue. So we all know about Holy Trinity, and we are in the city of Holy Trinity. But there is also one unholy trinity. So unholy trinity is cardiometabolic trinity, and that we'll be discussing. And I like the concept of duologue. Basically, I'll be asking questions to Ipsita, and Ipsita will be asking questions to me. So this is the financial disclosure. This is a Novo-sponsored symposium, and we are both sponsored for that. So coming to the first question, Ipsita, what are the cardiometabolic risk factors in diabetic patients?
Okay, now diabetes, if we look into all this data, before going into the cardiometabolic risk factors, we know about the current status of what diabetes prevalence is going to rise, and by 2050, probably 1/3 of entire India will be having diabetes, and most of the pre-diabetes. And definitely we need to understand the metabolic risk factors, because they ultimately lead to the various complications which occurs in diabetes. So hyperglycemia per se, and along with that the associated dyslipidemias, diabetic dyslipidemias, hypertension, aging per se, genetic risk factors which are not identified. Suppose a person is a smoker, that the weight parts, so Indians, they have that classic, we are the thin fat phenotype categories. Even at a lower so-called tentative machine which gives the weight parameters, our BMIs, even if they are lowers, we possess more of insulin resistance, more of adipo-inflammatory milieux. So ultimately all these things leads into the increase in the cardio risk metabolic factors, which sets into this multitude of complications which I do not have to discuss. So we just discussed this one, and PCOS is the upcoming risk factor which is coming, because out of 10, I think every third or fourth girl will be having some of the other part related to PCOS. Now this ultimately leads to a set of insulin resistance. So this is the entire risk factors, and if you look into this, there are Venn diagrams with multiple crossovers which leads to this trinity. So this is what I was discussing, that how the insulin resistance overlaps and how the entire thing sets in. So multitude of inflammatory markers, they ultimately lead to a setting of an altered adipocytokine milieu, and there is endothelial dysfunction, alteration at the RAS, and this is the entire pathophysiology which sets into, and there is a crossover of overlap between obesity, CVD occurrence, and T2DM. Okay, this is another data, and we have already discussed about that, that as of course we know that the cause of death in T2DM is most commonly due to the vascular related problems, of which CVD is important. The entire spectrum, CAD, CVD and PAD, or the lead what we call. Apart from that, one is important to note is that diabetic patients long-standing, they are more predisposed to stable angina, stable MI, because they have a component of autonomic neuropathy. So this is the same thing, it is the same overlap which occurs because of obesity, hyperglycemia, and how it worsens the cardiometabolic outcomes. So I'll go on with the next question, that what are the benefits that if we have a control over the glycemic status, could we mitigate the long-term complications in terms of both micro and macrovascular?
So we all know that increasing the blood glucose actually increases the complications, say it microvascular or macrovascular, and each 1% increase in the glycemic control, or if it is poorly glycemic control, then it increases all the microvascular like neuropathy, nephropathy and retinopathy, and also the macrovascular complication like coronary artery disease, peripheral vascular disease, and the CVA. But what about reversing the glycemic control? Suppose if we are doing a good glycemic control, whether we are doing benefit to the patient or not, I think that needs to be addressed. And it has been clearly shown by all the important trials, say UKPDS, DCCT, or the follow-up EDIC, or the UKPDS follow-up, or the advanced accord BADT, that with each percentage of HbA1c, definitely there is a microvascular complication improvement, almost like 37% of microvascular complication improvement. There is some evidence of reduction in the macrovascular complication also. With 1% reduction, there is 21% reduction in endpoint related to diabetes, for death related to diabetes, and 14% reduction in the myocardial infarction. And remember that 14% reduction was not exactly statistically significant as per the UKPDS data. Now, what we get from that? So, if we segregate all the data, then we know that with intensive glycemic control during the trial, the microvascular complications are bound to decrease, but macrovascular may not decrease at that time. But if we follow those chunk of people who are good control from the very beginning, young person, less comorbidities, and if we are bringing down the HbA1c significantly, then for the future, maybe 10 years down the line, there will be a significant macrovascular improvement. But the next question is that how early we should control the blood glucose control. I think this is a very nice slide which was supplied to us. So early glycemic control leads to long-term benefit. So if there is a 1% HbA1c reduction, we have almost 20% risk reduction of MI and 19% risk reduction for all-cause mortality. So that is if you are controlling within 1 year. But if we are delaying the reduction of the HbA1c by 10 years, or we are controlling someone who has come after 10 years and we are controlling the blood glucose by 1%, that benefit won't be there, because there only 7% risk reduction for MI and 3% risk reduction for all-cause mortality. So that again shows the famous concept of bad legacy effect, or the early good metabolic memory. So if you are controlling the blood glucose early part of the diabetes in a more stringent way, we will give the benefit to the patient in a more robust way. If you are controlling later, then probably we are not going to get that much of advantages. So these are the landmark studies. I have already told about DCCT and UKPDS in type 1 and type 2 diabetes. Those who are newly diagnosed, if you control the blood glucose significantly, all the microvascular complications will come down. But there are problem with Accord Advance and BADT, which has shown that if you are controlling the blood glucose very stringently in more elderly population, in more advanced diabetic population, where the blood glucose was uncontrolled for a long period of time with many complications, then probably you won't get any CV benefit, rather it would be a disadvantage to the patient, because the Accord trial was halted because there was an increased mortality. But again, at the same time, we got the study from EDIC and UKPDS that has shown that even at the time you are controlling the blood glucose from the very beginning, if you don't get the cardiovascular benefit, 10 years down the line, you will get some cardiovascular benefit, whoever has been initially intensively treated. So these are the conclusion of this trial, which I have shown in this particular slide, not to go in details about that. But that has actually changed the way how we go about in the glycemic control in terms of the guidelines. Because if we see the 2015 guidelines, it has clearly shown that glycemic control is the most important thing. You have this drug you control by this much of percentage. By 2018, it has changed to CV and mortality benefit we have to see from a drug. By 2019, it's the benefit of ASCVD and the heart failure which has come into play. 2022, they've clearly taken the GLP-1 receptor agonist and SGLT2 inhibitor as high up in the management of diabetes. 2023, they have completely changed this. Irrespective of the HbA1c, you have to start with a GLP or an SGLT2 inhibitor. And 2024 has told about the cardiorenal trinity. So cardiorenal risk reduction, glycemia management, and the weight control has clearly come into force in 2024 guidelines. And this is the 2024 guidelines. So use of glucose lowering medication in the management of type 2 diabetes, very complex slide, but I'll try to simplify that. So the first goal is to reduce the cardiorenal complication. If someone is having ASCVD, first choice of therapy is GLP-1 receptor agonist. If high risk for ASCVD is there, or high risk of CKD or high risk of heart failure is there, then again GLP-1 receptor agonist is the first choice. If heart failure is dominant, then you have to add a SGLT2 inhibitor. That is the first therapy, irrespective of the HbA1c, irrespective of you are giving metformin or not. And if CKD is predominant, again SGLT2 inhibitor is the first. If not getting control, add a GLP-1. So clearly there was a shift into GLP and SGLT2 inhibitor. Again, in the right side, goal is to achieve a good glycemic control with weight reduction. The first choice is to find out which drug induces a good glycemic control with weight loss, and there comes the role of GLP-1 receptor agonist or the dual, the tirzepatide, which is going to be launched in India recently, the GLP and GIP analogs. Achievement and maintenance of the weight is of paramount importance as per the 2024 guidelines. So with that, I'll go to the next question to Ipsita. Does early weight loss reduce the cardiometabolic risk factor? What's your opinion on that?
Now, 2024 ADA has summarized that Okay, 2024 has, as Dr. Sambit has already told, that 2024 now the emphasis is also that you have to take care of the weight part. Now we know, before I go into detail, that amongst the entire range of diabetic medications that we have, be it oral, be it injectable, there are few, or rather majority, which are commonly used, which causes weight gain. So yes, targeting the weight early is definitely important, because if you lead to a weight reduction, it will lead to benefit in the glycemic control. And how? Let us see. So if there is a weight loss or a weight improvement reduction is there, it will disrupt the pathophysiological mechanisms which leads to dysglycemia and insulin resistance. So, and along with that, there is good glycemic control. So ultimately, there are chances that the cardiometabolic risk factors will definitely be halted, or they will be taken care of. And along with that, suppose a patient who is a newly detected diabetic, there is always a chance that the disease can be slowed down, the rate of beta cell destruction may be prevented, and there is always a chance of remission in a particular category of patients if targeted weight loss is achieved. So ultimately, you will have a halting at the level of the micro and the macrovascular complications, and definitely the entire thing will impact the trinity of diabetes, that is the cardiorenal metabolic risk reduction. Now let us look into how much degree of weight loss would lead to changes at certain levels. So a weight reduction of every kg probably reduces the risk of occurrence of T2DM by 16%, and this is a data which shows that as high the weight loss is coming down, the occurrence of incident diabetes will also go down. So along with that, weight reduction will definitely improve your glycemic parameters, which is most commonly seen in day-to-day practice is HbA1c, the fasting plasma glucose values, and also to some degree the postprandial plasma glucose. So if you look into this graph, okay, if you look into this graph, the weight loss of approximately 50% risk reduction causes an improvement in HbA1c to the tune of around 1% the HbA1c is decreased, and sir has already told that the lesser the HbA1c is, or the dread is the degree of HbA1c reduction, then probably the occurrence of the micro and macrovascular complications are definitely lesser. Similarly, if you look into the fasting plasma glucose values, if the weight loss reduction is to the tune of 15, probably the fasting plasma glucose values can be brought down to 20 to 30 milligram in comparison to what it could have been achieved without a weight loss reduction. So greater weight loss definitely is achieved with all these improvements. And the data is also found from some two important studies. One is direct and look ahead, which basically looked into the diabetic remission data. So greater weight loss led to proportions of patients achieving and maintaining the diabetic remission. And look into the odds. There was 1.25 time odds of remission of diabetes probably at 2 years of, even if the weight loss reduction is there, there is a sustenance of remission until 2 years for every kg weight loss. So the more the weight loss, then definitely the proportion of participants undergoing remission was found more from the direct trial, and this was a very important study. Similarly, look ahead also gave certain data. There is what was the probable benefits that could have been found with a 10% weight loss reduction. So 10% weight loss reduction in T2DM patients and obesity had rather a 21% lower risk of a composite outpoint, which looked into 4 important data: death from CV cause, the non-fatal AMI, stroke, or admission into hospital for angina. So if you look into that, there was a 21% lower risk reduction within 1 year if 10% weight loss was rather achieved. And of course, there was some improvements in the secondary outcome. Multiple parameters were looked into the secondary outcome, especially CABG occurrence, if you go for a PCI, etc., etc. So everything favored weight loss from the data. Individualistically, also there was improvement in both the diastolic and systolic blood pressures, and we know that this is one of the CV risk factors. Improvement in the triglyceride values, increment in the HDL and decrement in the LDL, and we all know that diabetic dyslipidemia is different from dyslipidemia in the non-diabetics. So definitely if you look into the weight loss, there is improvement, and rather the more the weight loss, at least a 10 to 15% reduction in the weight gives us a I'm so sorry, there are probably some technical issues with the mics. Okay, so now interestingly, this is a very nice data which show that loss of 5% body weight in the year following diabetes diagnosis was found to have improvement in the risk factors, and also 48% risk reduction in occurrence of the CVD at 10 years from the date of diagnosis of T2DM. So greater the weight loss, if you look, highest 15% probably T2DM remission is achieved at that. And at the lower one, 5 to 10 and 10 to 15, you get benefit in terms of hypertension and occurrence of the metabolic liver diseases, MAFAL, which is renamed, decrement in the rate of reduction of GFR. All these things are definitely improved as the weight loss is more and more better. So high body weight increases CV risk in T2DM, and this is one data which shows that in probably 9 out of 10 patients who are having T2DM are on the overweight obese category. So high is the important that we need to address the weight parameters in the diabetic patients, and the more the weight, if you look into this, probably there is a 70% increase in all-cause mortality if the weights are on the higher parameters. Okay, so with this, we move on to the third question from Dr. Das, who would let us know about what could be the multifactorial benefit if we give oral semaglutide, the GLP-1 analogs, in managing diabetes.
Right, so from the very beginning, we have been talking about unholy trinity, and these are the unholy trinity. First is the diabetes, the second is obesity, and third is the cardiorenal burden. So it has been known that 90% of the people are overweight or having obesity at the time of diagnosis of diabetes. Overweight and obesity, more than 70% of the people with type 2 diabetes die of cardiovascular disease. 37% of adults with diabetes have been diagnosed with CKD, and 77% of patients with type 2 diabetes across India have HbA1c more than 7%. So just to highlight that, it's the diabetes, it's the obesity, and the cardiorenal burden are the three unholy trinity. Multifactorial intervention is very important. You have to control the blood glucose, you have to control the blood pressure, you have to control the weight, control the dyslipidemia and the platelet inhibition, and combinedly they have definitely a beneficial effect. In contrast to UKPDS and DCCT, the Steno trial, where they have taken multifactorial approach in management, has clearly shown there was a significant improvement in the cardiovascular outcome. So GLP-1 RA activates almost 7 pathways out of the ominous octet, let alone only the kidney part is left aside. Otherwise, the incretin pathway, the liver pathway, the muscle pathway, the neurotransmitter pathway, and the adipocyte pathway are all been activated or favorably activated with the GLP-1 receptor agonist. Now, which GLP-1 to choose? We have currently liraglutide, semaglutide, and dulaglutide, which are currently available in our market, but semaglutide has definitely a greater edge over the other GLP, why I will tell. Semaglutide has got 94% homology to that of the normal human GLP analog. And semaglutide is actually an injectable preparation, and the efficacy has been shown from the injectable background. But the problem is that injectable is not accepted by many, so we have to prepare a peptide which is accommodated in a pill so that the person can eat it. So semaglutide, what they have done is that they have combined it with another molecule known as the SNAC, SNAC, and then the oral semaglutide was created, and that's an absolutely game changer. Whoever is practicing, I think all of us are practicing diabetes and we are using GLP-1 as semaglutide orally. It's a absolute game changer for that. It's a co-formulation where the individuality of the semaglutide has been well maintained. So oral semaglutide has been undergone a very rigorous trials. There are almost 19 clinical pharmacological trial, 12 phase 3A trial, and almost 11,000 patients across the world has been exposed to oral semaglutide in the randomized control trial. And these are the pioneer program, the different phase 3 clinical trial of semaglutide. Just to highlight two important trials, Pioneer 2 has been actually compared with SGLT2 inhibitor, that is empagliflozin. Pioneer 4 has been tried in comparison to liraglutide. So these are, I find, the most interesting clinical trial in Pioneer, and the Pioneer 6 is obviously a cardiovascular outcome trial. So what they've shown is that irrespective of the way we use this oral semaglutide, either alone, combination, permutation, combination, cocktail, anywhere, you will find there is 1.5% reduction in the HbA1c. So any combination you will find almost 1.5% reduction in the HbA1c. Either as a monotherapy versus empagliflozin versus sitagliptin, liraglutide, and with insulin, the weight reduction has also been significant, 5 kgs. So what is more important to highlight is again the Pioneer 2, where empagliflozin has been tried. It has shown that compared to empagliflozin, the reduction of the weight is much more with oral semaglutide. And Pioneer 4, where liraglutide has been tried, it has also shown that in comparison to liraglutide, which was still the gold standard GLP-1 receptor agonist for weight reduction, oral semaglutide has been actually better than the weight reduction potential of the liraglutide. So that is more than 5 kg weight loss. The best part is that the weight reduction is not only the total body weight, so we know there is a significant weight reduction with oral GLP-1, but the best part is the body composition changes. It actually reduces more of the visceral fat, most of the fat mass, and preserves the lean mass. So that is the advantage of GLP-1 over SGLT2 inhibitors. Semaglutide has shown cardiovascular safety in the Pioneer 6 trial, where they have taken high-risk population. In one arm they have given oral semaglutide, the other arm they have given the placebo over the standard of care, and they have found that there was a 21% reduced risk of major adverse cardiovascular event, and it was non-inferior to placebo in terms of the cardiovascular outcome. But if we compare the Pioneer 6 with the Sustain 6, which is an injectable semaglutide and the cardiovascular outcome trial, combinedly they are in fact better in terms of the MACE outcome. So it's not only cardiac safe, it is actually cardiac beneficial effect. The Pioneer Real India real world evidence of oral semaglutide has been tried. The results has not been published, but they've taken in fact patients whose HbA1c is 8.9%. It's a real world data, and 90% were started for achievement of better glycemic control for this oral sema. 1 in 5 were started on oral semaglutide within 1 year of diagnosis, so early start has been there in this real world data. And 1 in 2 participants had CVD related history, stressing the need for an effective treatment option. So pharmacokinetics, so just one query which is always asked in many forums is that many of our diabetic patients are also hypothyroid and they take levothyroxine. So how the levothyroxine pharmacokinetic is changed with oral semaglutide. And here you can see that, in fact, levothyroxine co-administered result in an 33% increase in the total levothyroxine the availability, and but no effect on baseline corrected maximal total levothyroxine concentration. So how you are going to give a levothyroxine dose? So the recommendation from oral or the recommendation from the other guideline is that both should be taken under fasting condition, but taking levothyroxine at bedtime at least 3 hours after the last meal of the day could be considered instead of in the morning, and monitoring of the thyroid parameters can be done after 4 to 6 weeks. It is not practical in Indian setup because we take dinner at 9 p.m. or 10 p.m. After 3 hours, no one is waking up to take the levothyroxine dose. So what we do is we start with oral semaglutide first, wait for 30 minutes, and then we give the levothyroxine, wait for 45 minutes, and then you take your meal. So that's the Indian thing actually. So with that, I'll end. Thank you for the patient hearing.
Please take your seat. Sambit, please come. Actually, I think they have done very good to their topic, and whatever our question was there, the evolution of very long title, as you know, the exploring the novel horizon, navigating the cardiometabolic trinity in type 2 diabetes. It was a duologue, very interesting. She asked question and he asked question to her, and trinity, kidney, heart and metabolic, all three, and the horizon was taken navigating the existing options. So everything is discussed. Just I'll ask two questions, one to Professor Sambit, one to Dr. Ipsita, then we'll close this and we'll go to the next topic by our chairpersons. In India, the burden of diabetes and obesity is increasing, what all of us feel. And managing diabetes cannot go without managing obesity. How do you feel about that? And what is the role of the molecule you discussed in that context?
Absolutely, sir. I think I have shown the 2024 guideline and also the Indian guidelines also. They also stress that diabetes management is not only a glycemic control, but you have to see the comorbidities, and one of the comorbidities is obesity, and it is quite rampant. So this molecule at that point when we are treating a diabetes in a obese patient, I think it is a wonder drug, and it can be combined with metformin, it can be combined with SGLT2 inhibitor for a better weight reduction effect also.
Very appropriate. So next question is to Dr. Ipsita Mishra. We have combinations available. As we know, very commonly SGLT2 DPP4 combinations we use. They also help us in reducing weight. Metformin combinations also help reducing weight. So how do you see this molecule superior to those combinations?
Sir, as Sir has already told, there was a slide which showed into the data from Pioneer where there was a comparison with most commonly used some SGLT2 inhibitors and along with the DPP4. So DPP4 is basically a weight neutral drug. So it's a myth that DPP4 causes weight reduction. SGLT2 inhibitors do cause weight reduction, but not to the tune of GLP-1 analog, because some mechanisms of action of GLP-1 analog are basically acting through the hypothalamic part, which plays an important role also in weight reduction and appetite control. SGLT2 inhibitors do not have that. The degree of weight loss reduction, I am talking of weight loss, which includes the fat mass and also the lean muscle mass. Sir has already told, Sambit sir has already told. So that happens with SGLT2 inhibitors where GLP-1 analogs decreases the fat mass per se, which is the harmful one. So definitely GLP-1 analogs, they outweigh the reduction in the fat component versus the combination of SGLT2 inhibitors or DPP4, because DPP4 is technically a weight neutral drug.
Very appropriately said, and all of us have experienced the weight of diabetes is increasing. Number of diabetic patients are increasing, and the problem is increasing, and the problem of twin epidemic in the country, the obesity and diabetes, is going up. So in this context, it's a novel approach that we don't approach glycemic control alone, we choose drugs which can answer both. And in our practice we have seen patients have lost good control, achieved a target A1C. So while planning, we can go for molecules which will help us in this direction. So I thank Professor Sambit, I thank Dr. Ipshita for doing justice to their topic, and we'll move on to the next topic. Give a big hand for them. Thank you. Thank you, Sambit. Please wait for your memento downstairs. So next I request our chairpersons, and we have two very prominent speakers. We have Dr. S.S. Mangaraj who will be speaking, and Dr. Jayashree Shwai will be speaking for next two topics. I request our chairpersons, Dr. Prakash Patrashar and Dr. R.N. Karashar, to introduce the speakers and take it forward.
I have the pleasure to invite Professor Swayangsindha Mangaraj to give his talk on harmonizing diabetes care with insulin co-formulation, attributes beyond efficacy. The CV is presented, so I am not killing time.
Okay. Thank you, sir. At the outset, I would like to thank the organizing team, especially Jayant sir, for having me over here, and I would like to extend my congratulations to him for hosting an outstanding event in the land of Lord Jagannath. So I think we have already heard a talk about incretin. So I would be speaking something regarding insulin co-formulation, a molecule which has been with us for a couple of years now. So this is a sponsored Novo Symposium talk, and I'll be speaking on that behalf. So first, if you look at the projection of diabetes, needless to say, it is currently the pandemic of 21st era. I will just tell you the numbers. 543 million individuals have diabetes as of now. That number is going to increase to 650 million by 2030. By 2045, 780 million individuals across the globe would have diabetes. Just look at the sheer numbers and the kind of pressure is going to put on the healthcare ecosystem. So among them, remember, the brunt would be borne not by the US or UK, but by the third world countries and developing countries like us and African nations. This data was published by the INDIAB data from the ICMR, published in the Lancet only a year back. Just look at the number of diabetic. 100 million individuals have diabetes as of now. Equal number of people have pre-diabetes who are unaware of that. Coupled with that, just look at the numbers who have hypertension, dyslipidemia and obesity, because all of these together will culminate in a vicious cycle that will result in an adverse CV event. So you need to understand how optimally to manage from a more glucocentric point of view to a more cardio, renal and metabolic point of view. So roughly 8 out of 10 individuals do not have glycemic control. The picture is also not rosy. If you talk of US and UK, there also studies have shown 66%, 2/3 of the patients do not have A1C of less than 7%, despite we have 15 different class of agents to treat diabetes. And roughly 3 out of 10 individuals in India as of now take insulin to manage their diabetes. Dr. Ipshita has told you before regarding the thin Indian Asian phenotype. So if you compare versus a Caucasian, we have more insulin resistance at a lesser BMI, we have more visceral fat, diabetes is happening almost a decade earlier versus our counterparts, and there is a progressive beta cell failure. Many patients would be requiring insulin quite early in the course of disease. This study was published by 2014 in Joshi et al. The denominator is, if you compare north, south, east, west, we are a carb-rich eating diet across the ethnicity. From north, west, south or east, everybody, this study was conducted taking into a pan-India population. So roughly we all love eating carb-rich food. That's why the therapy we should give the patients should be tailored according to their needs, not just replicating what we get from the US or UK. So there is substantial difference between the incretin response of Asians versus Caucasians. For a similar kind of glucose load or a carb load, if you take that meal, South Asians, the postprandial surge would be 2 to 3 times higher with the same kind of carb content versus Caucasians. So there is difference even to response to food and drug. So we need a drug. In this regard, insulin like a IDAG-ASP, which can give you a good glycemic efficacy with lesser risk of hypoglycemia, a good mealtime flexibility, simple regimen, and that can be cost effective in the long term. So how cost effective? I will show you that. So as we all know, it is a co-formulation insulin containing two distinct molecules. One is the insulin degludec and one is insulin aspart. Both taking care of in a single shot, we are able to deliver an insulin which is going to take care of your prandial excursion, as well as in the same shot, it is going to give you an ultra long acting basal glucose control. Utility of IDEC ASP has been backed by numerous pivotal phase 3A and B studies which have been conducted across the globe, across geographies and ethnicities. So needless to say, the drug works quite well irrespective of the place you are going to put the drug in. It has been shown to be efficacious in type 1, early onset type 2, advanced type 2, type 2 with complications like CKD, CLD and CAD. So the drug is safe to use in across the class of type of diabetes as well as the complications those they have. That is also substantiated by real world evidence study published both from India and across the globe, which tells us that the drug not only works well in kind of RCT setting, but also in real world evidence where we clinicians practice in a common settings, the drug also is quite efficacious. So I will talk of some few studies only. The first one is a SMART study. So here the study design was including type 2 diabetes individuals who are supposed to be start on IDEC ASP. The efficacy data was the improvement in the fasting, A1C and postprandial by the end of 3rd, 6th and 12 months. And of course the safety endpoints, hypoglycemic endpoints. So this was a pan-Indian study conducted across 40 sites involving more than 1,000 individuals. So what they have shown is, if you look at the left hand of the panel, so among the individuals, 45% of patients were on insulin therapy were either on a basal plus minus OAD. So among them, 27 had previous exposure to insulin and 73% were insulin naive. They were only on oral antidiabetic drugs. So basal supported oral therapy is a common form of therapy which we prescribe once a patient fails baseline OADs. So what you see is, to just compare on the right hand panel, once you initiate IDEC ASP, it gives you a kind of comprehensive total control. You look at the fasting reduction more than 50 milligram, postprandial more than 80 milligram, and the A1C reduces by 1.8% at the end of 6 months. Safety endpoints. Confirmed hypoglycemia, the red bars are from the individual events that happened before enrolling the patient into the trial, and as the trial progressed, you see the number of hypoglycemic evidence or episodes significantly reduced. That means even in intensification of IDEC ASP, the molecule is quite safe. If you titrate, you have to learn one art of titrating. You just cannot blame the insulin every time you put someone on insulin, and the fear of intensification is something which all clinicians deal with as a part of clinical inertia, but that should not hinder you from intensifying the therapy in appropriate places. If you look at simplifying regimen, so basal bolus insulin regimen is the gold standard. There is no denying the fact that it remains the choice of therapy for type 1 and advanced type 2 who may not be managed with any other insulin regimen available in the basket. However, if you compare a basal bolus standard of care versus IDEC ASP twice a day, it is convenient. It gives you kind of similar A1C control with lesser number of pricks. It is hard to believe whether that can be achieved and documented in a RCT. So I will show you evidence of how IDEC ASP is non-inferior twice a daily IDEC ASP versus 4 times basal bolus. So this study involving 530 individuals was randomized in a fashion to give one arm IDEC ASP once daily, then intensified to IDEC ASP twice daily. The other arm continued to receive insulin glargine plus 1 shot of aspart, and if the need arises, they were put on subsequent twice or thrice daily insulin aspart when they continue to take the baseline OADs. So what at the end the summary is, IDEC ASP achieved similar kind of A1C versus basal bolus. There was significantly lesser number of pricks, 9% lesser dose of insulin which was given, and the patient were quite cumbersome to take basal bolus because of the number of injections they have to take, that kind of monitoring they have to do. That was not there with IDEC ASP. So you can switch IDEC ASP from any insulin the patient is currently on, be it insulin glargine U100, U300, premix twice a day or basal bolus. Remember, there is no in one theory fits all. You have to individualize. You just cannot tell that I have, after going from this seminar, or you put the patient from basal bolus to IDA gas twice daily, and the patient returns to you after 2 weeks with a blood glucose of 300. You cannot prescribe that to everyone, but if your patient is an ideal candidate who might have some beta cell reserve, is doing good with couple of OADs, you can definitely try twice a day IDA gas versus basal bolus. Quality of life. So this study, in which they were switched over from Glargine U100 or U300 to IDEC ASP. So what they have shown is the quality of life in terms of the questionnaire that was given to them, it is significantly better in patient who use IDEC ASP versus Glargine U100 or 300. So I'll just skip this. So similarly, if you look at the quality of life of insulin IDEC ASP, so 90% had improved quality of life because of lesser number of pricks. 90% found it comfortable because of social situations, only one major meal time they have to take it, and they could better manage their diabetes even in terms of their work culture or other associated findings. When you prescribe someone on a basal plus like IDEC ASP, there is significant reduction in the number of pills the patient is on. So once you reduce the number of pills, your health economics improves, compliance improves, and the control becomes better. So it is not only with regards to insulin control, it is also reducing the necessary dose of the complementary OADs which the patient is taking. So now a note regarding flexibility. You can prescribe IDEC ASP starting dose roughly 10 units as the major time of the day meal, which is carb rich, and also you can titrate twice a day. When the product was launched in the market, because Digludec has a half-life of up to 40 hours, it was told once a day is quite good, but now we know that it can be prescribed safely if the meal gap is at least more than 6 hours. Twice a day can safely be given. So this has to be administered with the largest meal of the day. So certain practical consideration, this is just an algorithm or something which we can start with. It is not that every patient would require this much titration. A obese individual, more insulin resistance, advanced diabetes might need an increment of 6 to 10 units, but someone who is lean, more insulin sensitive with CKD, you might go slow with plus 2 to 4 increments of insulin on a 2 to 3 day basis. One golden question will be, IDEC ASP is too costly, but whether that is cost effective in the long term. So this was shown as a poster by Manas Barua et al., in which they have shown, you just look at the bottom hand of the panel. So across treatment, if you compare the total amount spent out of the healthcare expenditure, it is 3,000 rupees less in individuals who took IDEC ASP. Now how come that be a fact if the molecule is so costly? Because the number of hospital admission, investigations, number of medications they need to take concomitantly with IDEC ASP was lower. So in that tune, IDEC ASP might be cost effective. I am not telling for everyone, but it may be cost effective in certain scenarios. So this insulin remains a choice because of low hypoglycemic potential, good flexibility, a good robust basal control due to Digludec, convenient, can be taken at any point of time, largest meal of the day, and it is quite efficacious, can be given in any advanced stage, early stage, or complications of diabetes. With that, I will end my case. Thank you.
Thank you, Professor Mangaraj. You have discussed very nicely the most innovative insulin of the day. So the topic is open for discussion. Any one question, because we are running short of time.
All our delegates have used the molecule. Sir. Mic.
I think people who are on premix twice a day become pregnant, then what we need to do?
Premix insulin should be continued, or it will be easier to take less pricks and small unit, although it is high costly. Can it be continued throughout the pregnancy?
I think you need to understand for that the pharmacology and pathology of gestational diabetes mellitus, how it is different from conventional type 2, because majority of individuals who have diabetes in pregnancy would require a more of a prandial control than a basal control, because fasting is not much of an issue in at least early GDM or early T2DM with diabetes. So perhaps the short acting component should be bit high. Premix might not work that well to control even the prandial surge. So putting them on like a RR3070 regimen would be better, but you can switch to IDEC ASP in pregnancy. There is data where the efficacy and safety has been established, but I think majority would not require IDEC ASP, but who require IDEC basal component support, then you can switch to IDEC ASP.
Can I have another question to you? It is the role of Sambit, but the question to be covered, you see, in pregnancy.
Sir, we can discuss in the floor. I think Dr. Mangaraj has finished. So please discuss with sir to close the topic. Well, actually, our invited faculties are there, 5 faculties in
thank you.
next session. So I request Dr. Kara to call the next speaker.
I invite Professor Jayasri Swami. Who will be planning now to kill 2 birds in one shot, that is Degludec in outpatient and inpatient. Dr. Swami, please.
Good evening, everybody. Thank you, Chairperson. Thank you, RSSDI organizer, Professor Jayant Bonda, for inviting me for this academic session. So my topic is 2 goals in one shot, Degludec in outpatient and inpatient. So coming to a case-based discussion, Mr. Ajit, 45 years, engineer by occupation, his BMI is 27, blood pressure is 149 by 86 millimeter of mercury. He is a known case of the type 2 diabetes for 6 years and hypertensive for 7 years, and patient is having dyslipidemia for last 2 years, and the family history of diabetes is present, and patient is very irregular in exercise and is a non-smoker, but alcohol intake it is 2 or more than 2 drinks per week. On investigation, A1C level is 9.2, fasting 202, postprandial 220, and there is no previous history of hypoglycemia. Total cholesterol level is 241, LDL cholesterol is 174 with HDL is 39, and calculated eGFR is 55 ml per minute, and urinary albumin creatine ratio is 200 milligram per 24 hour. And so my patient is type 2 diabetes, hypertensive, dyslipidemia with diabetic kidney disease and the risks of cardiovascular disease. And in that scenario, we advised diet, exercise and maintenance of the healthy weight. Patient is presently on antihypertensive therapy and statins, along with a combination of oral combinations of the anti-diabetic treatment, which includes metformin 2 grams once daily, liraglutide 1.6 milligrams per day, and that empagliflozin 25 milligrams once daily. The problems are here: uncontrolled glycemia, and the patient is having hectic life, and he travels often, and he is very fear for taking these injectables for the fear of the hypoglycemia, and he is unsure about that taking insulin in the fixed time of the day. So these are the scenario. In that scenario, definitely patient is on 1 injectables GLP-1 receptor agonist with the SGLT2 inhibitors and metformin. So our option for control of glycemia is only one, that is second injectable insulin. When you are going to the second injectable, according to this American Diabetic Association 2024 guidelines, if someone is with oral hypoglycemic agent, initiations of the insulin should be with basal insulin, or if someone is with GLP-1 receptor agonist, the next point is you can go for the basal insulin. Then which is the ideal one? The ideal basal insulin should be flat, peakless, and there is no risk of hypoglycemia, or risk of hypoglycemia will be minimum, and minimal variability, glycemic variability is there, and long duration of the actions, it will cover more than 24 hour or more than 24 hour, and flexibility in the injectable time should be there. These are the ideal characteristics of the basal insulins. So in this background, coming to the evidence, what are the evidence with us? We are giving this outpatient and inpatient. Quickly I will cover it. So if you look to the digludac, in this scenario, it has a prolonged duration of the action as compared to the glargines. And duration of action of digludac is more than 42 hours, whereas glargine 100 is 22 to 24 hours, and glargine 300 is 30 to 36 hours. In this background, there is a study called TRUST study that is Tresiva in the huge real world evidence. In that study, we will look to the efficacy of the digludac, in which A1C control is they are taken type 1 and type 2 diabetes, more than 1,000 type 1 and type 2 diabetes, and follow period is up to 12 months. At the end of the 12 month, the A1C decrease in the tune of 1.8%, and fasting decrease in the tune of the 70 from the baseline. So efficacy wise, it is very good for the OP patients. Next, coming to the glycemic variability, which is mostly discussed nowadays in all forums. So when you compare the digludac with the insulin glargines, by euglycemic clamp study, we can say that there is lower within the day glycemic variability is seen with the digludac as compared to the insulin glargine. There is two bar diagrams are with us. So the total glucose lowering effect was more evenly distributed across 24-hour dosing interval with the insulin digludac when you compare with that insulin glargines. And another point is that digludac is compared with insulin glargine 300. Here also, this variability within the day variability is less in case of the insulin digludac, and that is coverage around 24-hour coverage. Digludac had approximately 40% lower within the day variability of a glucose lowering effect when it is compared with the glargine 300s. So coming to that inter-day variability, what we have discussed, that is inter-day variability is also less with the digludac when compared with the insulin glargines, and also less with the digludac when compared with the insulin glargine 300s. So another important point is that it is a switch pro RCT where it is a crossover study. Patients are on digludac, they will change to the glargines, and the patient with the glargines, they will change to the digludacs. In crossover study, this, they look for the TIR and TBR. Time in range is 20 minutes more in case of insulin digludac, and time below range, that means nocturnal hypoglycemia is less. 12 minutes is less with insulin digludac as compared to the insulin glargine. So next point is our studies. We have RCT and real world evidence. RCT begin switch to devote is 3 RCT, and this you treat type 2 is the real world evidence. In all this RCT and this real world evidence clearly showed that overall hypoglycemia, nocturnal hypoglycemia, and severe hypoglycemia is less in case of insulin digludac when it is compared with the insulin glargines. Next is the insulin. When you compare with the digludac versus glargine 300, I will quote the confirmed study, and the data from confirmed study shows that this 30% lower rate of hypoglycemia with the insulin digludac when compared with the glargine 300, and episodes of hypoglycemia is less in digludac and as compared to the glargine. And flexibility. Next point is the flexibility. Sorry. We know the digludac 8 to 40 hours is the flexibility. Glargine 100, no flexibility. Glargine 300, you can go the plus minus 3 hours. So better flexibility to insulin digludac. And this potency wise, if you look to this area under the curve of the GIR, that is definitely better of the insulin digludac as compared to the insulin glargine, which is 30% lower potency in comparisons. So here we look to this bright study that fasting 23% lower dose of requirement is insulin requirement is seen in case of the insulin digludac, and better fasting control is seen with the digludac when compared with that of the glargines in type 2 diabetes patients. So here also the RSSDI guidelines, our recommendations is that glargines 300 require 20% extra dose. It is also seen in the RSSDI clinical practice recommendations for the management of the type 2 diabetes. Next point is the in patients. So we know the onset of the actions is 0.5 to 1.5 hours in case of the digludac, and glargines and 100 and 300 is more in comparison to that. So in these backgrounds, there is a digludac hospital trials. It is randomized control trials comparing the insulin digludac 100 with the glargine 100 in patient with type 2 diabetes. What happens? The mean blood glucose after 1 day was within the ADA recommendation rate, what we have seen in the bar diagram. Next point is that is the titrations, daily titrations. You can go for the daily titrations of these insulin digludac, and the publication studies and publications are there in 2021 and 23, which clearly shows that this better glycemic control with the safety, efficacy and easy titration. Next, coming to the EDS study, it is the prospective observational study in patients which shows that significant reduction in fasting capillary glycemia was achieved in the digludac. These are the CABG patient in patient CABG after in post-op period. So efficacy wise, digludac in patients fasting control is better. Then if you look to the glycemic variability, it is less, standard deviation is less when you start and at the end of the study, that is significant difference. So Indian data shows that there is low glycemic variability in patient, those who are taking this insulin digludac. So hypoglycemia rate from the Indian data EDS study is less in insulin digludac compared to the insulin glargine 100 and 300. So, and low risks of the hypoglycemia is seen in case of the insulin digludac in patient as comparison to that. So, it is approved insulin digludac. You can prescribe to this pregnancy, pediatric patient more than 1 year, adult, elderly and renal and hepatic impairment patient. So, we can use digludac, the entire wide range of the spectrums. So, to conclude my presentation, ideal insulins, basal insulins, maybe the insulin digludac, it is a flat, peakless insulins, and it is the risk of hypoglycemia is less as compared to the other basal insulins. Minimum glycemic variability is there, and longer duration of the action, more than 24 hours, it allows this dosing flexibility. So thank you for your patience hearing.
Thank you, Mr. Swami, for an excellent talk. This unique PD and PK ultra long acting insulin is almost revolutionizing the basal insulin management, and she has correctly told two great advantage is the nocturnal hypoglycemia is almost nil in this particular insulin, and another area is the variability that she has already told. Another two area actually, the dawn phenomenon and Somagi patients, they are exclusively good at this particular insulin. And if we select any basal insulin, we normally see the food aspect. This is food independent any time of the day and can give in safely. So this is an excellent insulin. One should recommend in all the cases, both was Professor Swami has told. So one question we can take from the audience right now. No answer. We stop here the session and go to the next session.
Thank you.
Thank you, Professor Swami. Actually, we had a very interesting session on all three molecules, the oral GLP-1 semaglutide, the co-formulation, as well as digludac. It is not only informative, that is latest in the intervention in insulin therapy as well as in incretin therapy. So I thank chairpersons, Dr. Prakash Patrashar and Dr. R.N. Karashar, and I will go to the memento bay for the memento. Thank you all. I request the speakers and the chairpersons to come to the memento bay. Over to Devashish. So we have a very interesting last session. Last session, I'm just giving an introduction because in Hall A, this is the last session. We have parallel halls on, so our audience are a little late. But after this session, we have very interesting program, entertainment program in this hall, and the GB will take place in the Hall B. And we have all invited speakers here. There's a slight modification for the exigency of our invited speakers. First, Dr. Virmani will be speaking his topic, followed by our usual sessions of Dr. Arun Kedia, Dr. Ajay Tiwari, Dr. Shaival Guha, and Dr. Bina Dhandhania will be here. All interesting topics, all invited speakers. Please stay back. There are tea outside. I'm asking them to serve it in the hall. And please settle down for this invited speaker session, after which the day one program ends in this hall. Over to Sandeep.
Sir. I invite the chairpersons for this session, Professor Dr. Lalatan Mahanti, who is a professor of medicine in KIMS, Bhubaneswar. Sir, please come over the stage. Then next, Dr. Soumyaranjan Mahanti, who is a medical officer in Government of India Health Department. Then Professor Dr. K.P. Tripathi, who is a professor of medicine in KIT deemed University, KIMS. Over to you.
Good afternoon. I welcome you all to the last session on Hall A, and we must congratulate Dr. Jayant Panda and his team for organizing such an event, which is gala event. And to start the session, we have with us the only man, Dr. Anil Kumar Virmani, who is a faculty, School of Diabetes India, faculty regional Yorkshire Foundation Teaching Program UK, executive council member Institute RSSDI, and advisory council member Advanced Career Physician of American College of Physicians, and he is the best internist of the year 2022 ACP India chapter. And he is here to talk to us. Please, sir, the stage is yours.
Thank you, sir, honorable chairpersons and dear friends. The topic of today is lipid conundrum in diabetes. No disclosures. The first thing that comes to mind is what is the meaning of conundrum? It means basically an intricate and a difficult problem, a riddle which contains a pun. For example, what's the difference between a jeweler and a jailer? One sells watches and the other watches sells. Now, in type 2 diabetes, what is known is, it's called as atherogenic diabetic dyslipidemia. And what's the pun here? In diabetic dyslipidemia, triglycerides have all the fun, yet is the LDL that's the target number one. So that is the conundrum in the atherogenic diabetic. And the lipid conundrum in diabetes represents a significant challenge due to its complex interplay with insulin resistance and its impact on cardiovascular risk. So comprehensive management in combination with lifestyle interventions, pharmacotherapy, is essential for reducing the burden of cardiovascular disease. Now we know that as far as the non-communicable diseases are concerned, dyslipidemia ranks amongst the topmost in the prevalence. And if you look at the prevalence of dyslipidemia and abdominal obesity in our country, it is more in the urban residents. Almost more than 80% of the subjects have some sort of dyslipidemia. Decreased HDL is seen in almost 67%, hypertriglyceridemia in 30%, and elevated small dense LDL in around 12%. So the key components of diabetic dyslipidemia are a low HDL cholesterol, elevated triglycerides due to increased hepatic production and decreased clearance, increased small dense LDL particles making them more atherogenic, and postprandial lipemia, which we often tend to ignore. Now, what are the mechanisms? Of course, insulin resistance is the major culprit. This leads to increase in the free fatty acid reflux from the adipose tissue, stimulating hepatic triglyceride production, increased apolipo-B production, and altered lipoprotein lipase activity, which is crucial for the breakdown of triglyceride into lipoprotein. Next question comes, what is the clinical implication? And we know that it leads to increase in both the micro and macrovascular complications. So both the cardiovascular risk as well as the microvascular complication. Now, why the primary focus is on lowering LDL and not on triglycerides? That's a question often asked in diabetic dyslipidemia. Now, we know from various studies and various data that we have today that elevated LDL cholesterol is a well-established risk factor. Increase in LDL leads to increased CVD, and a decrease in LDL decreases cardiovascular disease. And given the fact that individuals with diabetes have a higher risk of CVD, it is but imperative to reduce LDL in these patients. Moreover, we have effective therapies for LDL, and we don't have much for triglyceride. We know that all of you know that statins are the cornerstone of therapy as far as LDL is concerned. I don't say triglycerides are not important. Yes, they are important, but they are important in a different way. As an independent risk factor, they do not have much to contribute. So what happens is that managing triglycerides is still important, but it often comes once we have got the LDL in the therapeutic goals. Now, it was way back in 2011 when the American Heart Association gave this statement. Triglyceride is not directly atherogenic, but represents an important biomarker of CVD risk because of its association with atherogenic remnant particles and ApoC3. So it is the bad company that it keeps has made triglyceride notorious. An optimal triglyceride cut point is only intended to define one physiological parameter of cardiometabolic health. It does not represent a therapeutic target because there is insufficient evidence. We know that once the triglyceride is raised, there is increased CVD, but if we lower triglyceride, we are not able to lower cardiovascular disease. So all evidence, whether it be from epidemiology, Mendelian randomization genetics, RCTs, animal studies, all support the fact the biggest culprit is LDL, and hence it is the first target. Now, there is a paradigm shift. When we talk about LDL, there is a concept of cholesterol years, how long the patient has had the burden of increased LDL. A child from birth, if it's severe hypercholesterolemia, has the highest risk, whereas a modest hyperkalemia from adulthood has a much lower risk. And if the LDL is low right from genetically, these patients almost do not have any cardiovascular disease. But we must remember, even after lowering LDL, there is something called residual risk. And what is this residual risk? The PESA study demonstrated that hypertriglyceridemia is associated with subclinical atherosclerosis and vascular inflammation in individuals with low to moderate CVD risk. And what is this because of? It is because of the remnancy greater than or equal to 30 milligram has a higher risk. So it is not triglyceride per se. Again, it is the cholesterol remnants that are the bad company that it keeps are responsible for it. And if both are there, LDL is raised, there are cholesterol remnants, risk is obviously much higher. So how do we capture this? By what is called as non-HDL. But before I go to non-HDL, we must remember that inflammation in the atheromatous plaques also contributes to residual risk, and hence there is a current recommendation of using low-dose colchicine in patients where you have got a normal or you have controlled LDL, normal triglyceride, but a high level of hsCRP. So low-dose colchicine is now recommended as an anti-inflammatory agent. So the non-SDLC is nothing but total cholesterol minus SDLC, and it covers almost all the atherogenic proteins, right from ApoB, right from the chylomicrons, remnants to VLDL to ILDL, and small dense LDL, and even LP little a, which is a very big upcoming target that we are thinking of. We all know when we are trying to reduce LDL, we are using various drugs in combination to get the reduction levels. But we must remember two things. The amount of risk reduction is similar in major events depending on the amount of LDL that is reduced. So if you are using a high intensity statin, say 40 milligram or Rosuva or 80 milligram or atorvastatin, the risk adverse effects are more. So the higher this dose of statin therapy, more the risk. So there is again a paradigm shift in the concept of treatment of these lipids. From high intensity statins, we are now talking about high intensity lipid lowering. And that basically means early combination therapy along with, say, other drugs that are there. And we all know how much by moderate intensity is 30% reduction in LDL and so on. And if you're using with ezetimibe, it's 65%. If you're using a PCSK9 inhibitor, it's 60%. And if you're using all, it is 85, almost 75 to 85% reduction. So it's simply a matter of mathematics when you're trying to treat these patients. Look at the atherosclerotic cardiovascular disease score. What is the score? Once you know the patient is low risk, moderate risk, high risk, then you decide what should be his LDL target. And I'll talk about what the LDL targets are basically for that. Once you have decided the LDL target, you have the patient's LDL level and you have the target, you know how much percentage reduction is required. So if the percentage reduction required is more, you need to start with double therapy or even triple therapy. So it is just a question of mathematics, very easy. Now next question is how low should the LDL be brought down? Now we know when we are trying to break down blood pressure, there is something called a J curve or infraphysiological values. Similarly with glycemia, hypoglycemia again is bad. But there is no infraphysiological value as far as the LDL is concerned. And the LDL lowering is linear shape as far as the benefit is confirmed. And recent studies like Fourier, Odyssey, Prove It have shown that even if you get the LDL down to less than 50, still there are no adverse effects. So there are a lot of benefits of lowering LDL to less than 30. Coronary atherosclerotic plaque regression. There is a statistically significant decrease in the cardiovascular death, myocardial infarction, ischemic stroke, coronary revascularization, and unstable angina. However, there is paucity of data regarding lowering LDL to less than 15. There are certain side effects, new onset diabetes, but then the benefit risk ratio is in favor of the use of lowering the LDL. Now, we know that, and this is the latest from the American Heart Association statement published just October 23, that there is no data to conclude that statins or low LDL cause cognitive impairment or dementia, because that was one concern that was there earlier. Even the second concern of hemorrhagic stroke with PCSK9 inhibitors is again very statistically insignificant. In fact, on the other hand, there is a reduction in the total number of strokes because there is a reduction in the ischemic strokes. So that thing has not been taken care of, and we can go even less than 30 milligram. And these are the guidelines from the Lipid Association of India, which I follow, and I think all of us should be following the Indian guidelines. And they've said in patients with low risk, try to get the LDL to less than 100, and in low to moderate, in high risk less than 70, and in very high risk less than 50. Once you have got the LDL, then you look at the non-SDL, which is 30 milligram more. When to start drugs? When the LDL is more than 130 or non-SDL is more than 160. Now, LAI has also come especially for Indians, and this is not seen in any international guidelines. We have very high risk group and extreme risk group. And there are the factors here. I will not go into the details because of the paucity of time, but patients who are already established cardiovascular disease, the LDL-C goal is less than 50 and optional is less than 30. In category B, extreme risk groups, you have to get the LDL to less than 30. Now, we have number of drugs with us in treatment. You all know statins are there. They are the most commonly used drug. I don't have to talk about it. Then we have the azithromycin, which is the most common combination being used with statins. We have the oral bile acid sequestrants, hardly used because of the serious adverse GI effects. Then we have the evinacumab, that is the injectable monoclonal antibody against the angiopoietin, but very exorbitant, costly, and usually not used. Then we have the PCSK9 inhibitors, the alirocumab and evolocumab, which are being used mostly by the cardiologists to get the LDL to as low level as possible. And fortunately for us, treating physicians, we have now another oral drug, bempedoic acid, which is available, which is the oral ATP citrate lyase inhibitor, and it has shown good CV outcomes. Of course, then inclisiran is the latest kit in the market, and to be given injectable twice in year, and it's a wonderful. It can reduce LDL by almost 65 to 70% with hardly any side effect. Now, there is a fundamental principles we must of LDL lowering therapy we must understand, and all trials of LDL lowering have shown that relative risk reduction is in direct proportion to the absolute risk reduction. Otherwise, we talk about a relative risk reduction and we tend to ignore absolute risk reduction. The lower is better. Lowering LDL with statins, azithromycin, or in combination PCSK9 doesn't matter as long as you get the LDL goal. And the intensity of LDL lowering is going to depend irrespective of the cause of the risk and on the baseline LDL level. So the modern concept of lipid lowering strategy, concept change one, start early. Less lipid exposure leads to prevention of atherosclerotic plaques. Concept change to treat much more aggressively. So now today we are talking about trying to eliminate LDL-C in the blood. And the concept change 3, use early combination therapy to get the LDL levels down as early as possible. And this is the dawn of a new era of targeted lipid therapies. We started with daily, monthly, weekly, biannually. We have injections now annually. I talked about inclisiran, and then we are also talking about gene editing for permanent for life and looking at the development of new vaccines. But remember, LDL-C remains the main target. Non-SDL, including remnants, is the co-target or secondary target, and Lp(a) is the new target. What about elevated triglycerides? What do we do with that? They are definitely a marker of risk and possibly a marker of underlying disease. Higher triglyceride is associated with higher CV risk in diabetic patients. There is no doubt about it. Every 50 milligram increase in triglyceride level was associated with increase in cardiovascular death, MI, stroke, with a hazard ratio of almost 3.2%, and increase in CV death with 5.8%. But again, I like to re-emphasize here, it is because of the cholesterol remnants, which upon entrance into the enteromer leads to low-grade inflammation, foam cell formation, atherosclerotic plaques, and ultimately cardiovascular disease and increased mortality. So once we see we have got the LDL to goal, we look at the triglycerides or non-HDL and try to rule out the secondary causes, the lifestyle causes, especially alcohol abuse, obesity, etc. There are certain diseases, metabolic syndrome, diabetes, nephrotic, and so on, and certain medications like oral contraceptives, steroids, antipsychotics, and thiazides and beta blockers. A number of things, secondary causes of hypertriglyceridemia has to be ruled out. As far as treatment is concerned, we know the fenofibrate failed in the field trial. It did not significantly reduce the risk of primary outcome of coronary events. It did reduce CV events, but they did not reach statistical significance. But remember, most of these patients were on statins, so that could have been one cause. The CARD study has shown that in patients who were not on statins and they did not have prior cardiovascular disease, there was some benefit, a significant benefit of major cardiovascular events. 27 patients were needed to treat for 4 years to prevent one CVD event in one patient. But the secondary outcome, the two extra benefits that we got was that it reduced albuminuria and it retarded diabetic retinopathy. So fenofibrates now are the drug of choice in retarding diabetic retinopathy today. Again, another trial, prominent trial with pemafibrate, again failed, and it was said that this is the last nail in the coffin of fibrates. Fortunately, we came to the REDUCE-IT trial with icosapent, and it had a wonderful outcome. The primary outcome was reduced by 25%, secondary outcome by 26%. The primary outcome was CV death, non-fatal MI, stroke, revascularization or unstable angina. So it was concluded that among patients with hypertriglyceridemia, despite the use of statins, the risk of ischemic events, including cardiovascular death, was significantly lower in those who received 2 grams of icosapent ethyl twice daily than those who received placebo. And this was reinforced by the PACME, by the European Society of Cardiology and Atherosclerosis Society, lipidemia guidelines in September 2019.
Out of time, sir.
Yeah, just 2-3 minutes. Saroglitazar is one drug that we are all using. Now, what is the difference between saroglitazar and fenofibrate? Saroglitazar is dual action alpha gamma, that is only this PPR alpha reaction with fenofibrate. Now, this does not have any effects on the renal function of the liver. That can impair renal function. So, fibrates should not be used in patients who are having impaired renal functions. And the risk of myalgia and gallbladder stone is not there with saroglitazar, but it is there. The reduction in triglycerides is far superior with saroglitazar as with fibrates, and the drug interaction is neutral. So definitely saroglitazar tend to score over fibrates, and when we know that both of them do not have any positive outcome study, why not use a drug without any adverse effects and a better triglyceride lowering? And the amount of lowering is given here, triglycerides almost 45 to 62%, cholesterol 26%, non-HDL, LDL, etc. So how do we manage hypertriglyceridemia? So when you see a patient with hypertriglyceridemia, try to achieve the non-HDLC goal. If the normal triglycerides are there, continue with lifestyle modification. If the triglycerides are between 150 to 499, you have to decide between two things. Does the patient have atherosclerotic cardiovascular disease or diabetes? No. Continue with statin, add ezetimibe. But if the patient is a known diabetes, has a risk, high risk, or has atherosclerotic, we must add icosapent ethyl to these patients. Because that main aim here is to prevent atherosclerotic, and we know only one drug, icosapent ethyl, can help us there. Triglycerides more than 500 to 1,000, the main aim is to prevent pancreatitis. You can use anything, fibrates, saroglitazar, but definitely not both together. So the key messages I want to give you is LDL is causal for atherosclerotic cardiovascular disease. Primary target, the lower the better, the earlier the better, the longer the better. Once at LDL goal, non-HDL should be targeted. That is the co-primary target. Lp(a) is an emerging target requiring intensification. But what is most important, getting to guideline recommended goals is okay, but staying there will prevent further CV events. So when somebody asks you, how long should I continue statins? The answer is lifelong. That's all. The challenges of diabetes reminds us that life is about resilience and adaptation, much like our body's response to lipids. Thank you for a patient hearing.
Thank you, Dr. Bhimani, for a lucid presentation and taking us through the conundrum of lipids in diabetes. You have told everything like LDL, non-HDL, triglycerides, and lipoprotein lipid also. I think no questions is needed, and if anyone.
Yeah, please.
Only one.
When triglycerides are more than 500, you can use either saroglitazar or fibrates, but not both together. But even you can add icosapent ethyl to them if you're not able to reduce. In my clinical experience, I prefer saroglitazar because it does not have much adverse effects, And I have been able to reduce triglycerides from 900 to around 180, 200, which saroglitaz alone, which fibrates could not do. So I personally feel that saroglitaz have a much potent triglyceride lowering effect as compared to fibrates. Of course, with intensive lifestyle modification.
Thank you, Dr. Birmani. Sir,
Yeah.
we'll discuss on the floor. Thank you, Dr. Birmani.
Sorry?
Sir, you can
You are
discuss
giving
with
statin.
Dr. Birmani on the
You
floor.
are giving statin. Statin you cannot avoid.
We close the session. Thank you, sir. Thank you, Dr. Birmani.
Thank you very much.
Thank you.
To speak on this,
आपने उसको बोला था ना, इससे पहले मैंने भेज दिया।
So I thank the organizers of RSSDI ODISHA, the 12th in addition, to have me here as a faculty. And I would be throwing light on the topic that is allotted to me, that SGLT2 inhibitors in type 2 diabetes. So being very specific, I will not speak anything on type 1 diabetes. So this data of the epidemic of diabetes has been repeated many a times since today morning, so I would not go into the details. But what is important to understand is the natural history of type 2 diabetes. And even before the diagnosis of diabetes, we know that the risk factor for diabetes have already set in. So there is a problem of the weight, there is a problem of dyslipidemia, there is a problem of insulin resistance, hypertension, impaired glucose tolerance, and then by the time the diabetes is diagnosed, the patients have already started developing macro and microvascular complications. So this is the background natural history that we need to keep in treating our patients of diabetes. And at the same time, now we are convinced that diabetes has a continuum cardiorenal metabolic risk, and that has been explained to us since morning in a number of lectures. So what is important from these two slides is to understand the goal of our treatment is not only glycemic control, but we need to think beyond glycemic control. So at the same time, while we start treating the glucose to the targets, we need to prevent or delay the progression of micro and macrovascular complications, improving the quality of life of our patients and decreasing the morbidity and mortality of the patients related to diabetes. And one of the major reasons for mortality is the cardiovascular death. So all the therapy till 2014 that we had in the form of insulin, the metformin, sulfonylureas, meglitinides, DPP4 inhibitors, they had some limitations in the form of hypoglycemia, weight gain, beta cell fatigue, GI side effects, and reluctance for injections of insulin. And as science keeps evolving and the researchers keep thinking about what next can be done, there was a continuous search for some molecules which could address all these limitations. So if we see the conventional therapy till 2014, and if we compare all of them, you can see that not all of them can provide all the benefits, and that is how we still had patients with residual cardiovascular risk. So all these drugs, even though were used widely, the cardiorenal complications still needed some attraction, still needed some attention of the researchers, and therefore the drugs they needed that could target the cardiorenal complications were the need of the hour, and that's how the SGLT2 inhibitor came into the picture. So 2014 for India or 2013 for the globe, the SGLT2 inhibitor was finally born. And this drug was born to tackle not only the hyperglycemia that we see in diabetes, but also to provide the cardiorenal protection in all the patients of type 2 diabetes that we see. So a bit about the physiology. We know about the SGLT2, the SGLT receptors. This is the chart which shows the location of the various SGLT receptors. but the primary importance, the SGLT receptors are the SGLT1 and SGLT2, and there is a slight difference between them, and the target was SGLT2 because of their low affinity and high volume membrane receptor, which performed 90% of glucose reabsorption at the proximal convoluted tubule level. So this is the evolution. The molecule was in search since 1830s when fluorescein was shown to have some glucosuric effects, and what they found was the structure which could inhibit the SGLT2, and this was how the evolution started. From 2013 to 2014. We had 3 major molecules which came into the market, and we all know the names of these 3 molecules. The physiology again is known that SGLT2 is responsible for 90% of glucose reabsorption in all our normal subjects, but what happens in type 2 diabetes, the renal pathology speaks that in type 2 there is upregulation of SGLT2 receptors which lead to extra glucose absorption, and that is where the researchers thought that if we could block these SGLT2 inhibitors, probably we could reduce the glucose reabsorption and thereby cause glucoseuria, which could let the sugar flow out of the kidney and thereby cause a good glycemic control. But that was not the only thing. The researchers saw it from a glucosuric point of view, but the regulatory timelines by which these drugs came, there was a lot of learning from all the various trials that these drugs underwent. So from 8th January 2014, when this drug was approved for only the management of type 2 diabetes, by the time next 5 years, it came to be known for type 2 diabetes with heart failure hospitalization, and subsequently it was also used for heart failure patients with reduced ejection fraction, and subsequently for all type 2 diabetes patients with CKD. And the journey continues today that now it is used even for patients without type 2 diabetes. So if you see the whole spectrum of SGLT2 inhibitor usage, you can see that in patients for where you are thinking only for glycemic control, you can use it in patients of newly diagnosed diabetes, uncontrolled diabetes, you can add on to insulin, you can use it irrespective of age, independent of HbA1c, you don't have to think of hypoglycemia, and the durability of this drug is such a good that you can use it on a long-term basis. When you think of spectrum of CV disease, it does take care of hypertension, it does take care of obesity, it takes care of dyslipidemia, and it does take care of the endothelial dysfunction. At the same time, it takes care of microalbuminuria, thereby showing some renal risk reduction. And of course, to this list, we should not forget the fatty liver. So the key benefits of SGLT2 inhibitors in diabetes is not only in terms of glycemic control, but in terms of also cardiac protection as well as renal protection. So coming on to the impact of HbA1c. Now this part of the presentation of mine would basically try to enforce on you that we need to use SGLT2 inhibitors upfront in all our type 2 diabetes patients. So if you see the impact on HbA1c, the multiple systemic reviews and RCTs were taken into account, and there was a consensus made by the Indian scientists, and what they declared was that SGLT2 inhibitors can be considered as first line in the management of type 2 diabetes with or without metformin based on its impact on HbA1c. The class of recommendation was given once 1 and the level of evidence was A. So this is a very, very strong evidence in favor of SGLT2 inhibitors with its impact on HbA1c. And similarly, if you see the impact on glycemic variability, it has shown to improve glycemic variability based on multiple RCTs which have compared this drug. And again, the recommendation was that it can be used as a first-line agent in order to reduce glycemic variability, similar to metformin. Now, its function on beta cell, it has shown that there is definite improvement in beta cell function, but we do not have a direct literature on comparison of SGLT2 inhibitors with metformin with regard to their beta cell function. And so the class of recommendation given was class 2 and the level of evidence was C, but we do have some evidence where it shows that it improves beta cell function. We all are convinced with the fact that it improves insulin resistance, and you can see that the class of recommendation again to improve insulin resistance is 1A, and that is again a very, very strong recommendation which can be thought of as using SGLT2 inhibitors in diabetes as an upfront first-line therapy. Impact on weight, we all have a practical experience of almost 3 to 5 kg weight loss in all our patients. The weight loss is better than what we see in metformin also, and this weight loss is sustained in all our patients. And especially with the rise of diabetes, we all need to tackle this particular aspect of diabetes patients, that is weight management. There is almost 4 to 6 millimeters of reduction in systolic blood pressure and 2 to 3 millimeters reduction in diastolic blood pressure, which further gives an edge to SGLT2 inhibitors to be classified again as one of the first-line agent that you can use in patients of type 2 diabetes wherever you want to cut down the cardiovascular risk of these patients. There is a definite improvement on lipid profile. There is a reduction in LDL, and again, this drug steps up from an add-on therapy to a first-line therapy compared to metformin in decreasing LDL cholesterol and increasing HDL-C cholesterol. Now, the beauty of this drug is that you can combine it with almost every oral hypoglycemic agents. And we now know in the Indian market, we have fixed dose combinations with DPP-4 inhibitors, we have combination with metformin, and now we have also combination with sulfonylureas in the market. So almost all the class of oral anti-diabetic agents have been combined safely with SGLT2 inhibitors, and we have a lot of practical experience to use it in our day-to-day practice now. It is safe with insulin, and it has been found that it reduces the requirement for insulin. At the same time, it mitigates the weight gain that we get with insulin. So if you combine with insulin, you can have dual benefits, one in terms of glycemic control, the other you can also cut down the weight gain which happens with insulin. So again, it gets a level evidence, level of the class of recommendation as 1A to combine with insulin. And what you can see that when you combine it with insulin, there is a stability of the dose of insulin when you prolong this SGLT2 inhibitors with insulin. So patients remain on the similar dose of insulin for a quite long time, and there is much lesser risk of hypoglycemia. So there is a definite reduction in HbA1c, there is a definite reduction in weight, and there are reductions in hypoglycemic events. So low risk of hypoglycemia, we all know that this drug does not belong to a category which depends on insulin secretion. So that is why we don't expect hypoglycemia. But of course, when you combine it with drugs which are secretagogues, then definitely we need to reduce the dose of secretagogues. We need to reduce the dose of insulin in order to get the benefit of SGLT2 inhibitors. Cardiovascular protection, I think we have huge data now with the 3 major landmark trials in the form of EMPA-REG, the defined TIMI trials, and then we had the Credence, and all these trials have shown that there is a class recommendation to 1A for reducing cardiovascular disease in all our type 2 diabetes patients, and we all know that the guidelines now focus on ASCVD reduction, and we have seen that this drug has stepped up to step number 1, irrespective of the baseline use of metformin, irrespective of the baseline HbA1c, either this drug or GLP-1, whichever the patient can afford. This is the mechanism by which it reduces the heart failure hospitalization, and we know that it reduces the interstitial fluid volume, which causes a reduction in heart failure incidence. The renal protection was another composite endpoints which we saw in all our CVOT outcomes, and thanks that we have now dedicated kidney trials where this drug have shown to be very, very important drugs, to the extent now that this drug has been recommended even in patients who have non-diabetic kidney disease. So class of recommendation again is 1A when it comes to renal protection. This statement was given by Eugene Braunwald that SGLT2 inhibitor is a new statin, and this should be used in all patients with cardiovascular disease unless not tolerated or contraindicated. And this was a landmark editorial which he had written, and this was something which is, we have realized that it is almost as good as statins and aspirin when it comes to cardiovascular protection. In the management of NAFLD, this has now been introduced in the guidelines to control the disease and thereby reduce the progression from NAFLD to liver fibrosis. There is a good modulation effect also on the gut microbiome, but this again is not known for many studies, and so the level of evidence that we have is still class 3, but this drug can be seen as a drug which probably modulates the gut microbiome in order to modulate it in favor of the metabolic disorders. There is studies which shows that SGLT2 reduces uric acid level, thereby again reducing the metabolic risk in patients with cardiovascular disease. But the most important thing when we talk about SGLT2 inhibitors versus GLP-1RA, this is the factor which comes into the picture, that is the cost effectiveness. And when you talk about the cost effectiveness, again, if you see the class of evidence for this particular drug is level 1A, because this drug now is available at a very, very cheap cost, almost as cheap as a sulfonylurea or metformin combination now, and that is why we can actually incorporate this drug into all our patients of type 2 diabetes. So hardly you will find anyone with type 2 diabetes who would not benefit from SGLT2 inhibitors, and I think the House will agree to this particular statement that almost every patient would benefit from this particular drug when it comes to management of type 2 diabetes. And this picture shows the various studies and the various parameters on which this drug was evaluated, and they found that 15 endpoints on which 11 endpoints got level evidence A for its indications to be used. Of course, all drugs which have some good effects will have some bad effects, and we need to keep some adverse effects and side effects in mind, and the most common is the genital and mycotic infections, where we need to be a bit more cautious. We need to train our patients for adequate hydration and hygiene in order to mitigate the risk of mycogenital infections in all our patients. But if you see the balance between the risk and the benefits, of course, I would say the benefits outweigh the risk, and that is why we should ignore the risk, which is minimal in terms of the benefit that this shows. So these are the considerations that we need to keep in mind when we initiate patients of an SGLT2 inhibitors. We need to treat them, we need to teach them about the hygiene, we need to teach them about the hydration, we need to tell them about the sick days precautions, we need to withhold this drug whenever the patient is acutely ill, and we need to teach them the symptoms of diabetic ketoacidosis, because there is some risk of euglycemic ketoacidosis with this particular drug. However, the incidence is again very, very minimal. So if you see the ADA 2024 standards of medical care, we need to have lifestyle modification and diabetes education. On the other hand, we need to have reduction in diabetes complications, for which we need to have a glycemic management, blood pressure management, lipid management, and an agent with CV and renal benefit. And I think the only two classes of drugs which match all of these are the SGLT2 inhibitors and the GLP-1RA, out of which SGLT2 inhibitors is a class which is affordable by majority of our patients that we see. So the journey has been very short, but the journey has been very, very phenomenal. So from phase 3 trials of type 2 diabetes, where the drug was tested only for glycemic management, the drug has moved on to show its success in all CVOT trials. It has gone its tests in all the heart failure trials, and it has been successfully tested in all dedicated CKD trials, and it has shown that this drug benefits across the entire spectrum of cardiovascular disease, across the entire spectrum of renal disease, irrespective of whether you have diabetes or you don't have diabetes. And the journey continues. I think this molecule probably in future will reveal to us some more secrets, some more benefits in the future, and that is how we are blessed to have this drug in this last decade. With that, I thank you all for a patient listening.
Thank you, sir. Thank you very much for the extensive presentation of SGLT2 inhibitors. We are using this drug for quite a few long time now, and we all are experienced in this. We can take up a single question if possible on this. Sir.
No, I think canagliflozin did not undergo a dedicated cardiovascular, dedicated heart failure trials as well as the dedicated kidney trials. It was only the outcome that it was shown on the CVOT trials. But EMPA and DAPA have subsequently undergone various heart failure trials as well as the CKD trials. And that is why they have got a better score over canagliflozin. But I think SGLT2 inhibitors overall should be seen as a class rather than as an individual molecule. Individual molecule could be a preference of individual doctors, but I think the message should be that SGLT2 inhibitors should be a part of therapy for all diabetes patients unless contraindicated or there is intolerance to SGLT2 inhibitors in the form of recurrent genital infections, recurrent mycotic infections, where again we have very, very few patients who complain such type of clinical issues. Sir? So which, EMPA? Empagliflozin, sir, you have two formulations, 10 milligram and 25 milligram. The HbA1c reduction, if you see the comparison, it is only 0.2% extra with 25 milligram. But the weight reduction is approximately 1.5 kg more with 25 milligram compared to 10 milligram. So it all depends upon what you want to target at. Sir? So whenever we think of combining the drugs, we need to first, when we start the patient on any drug, we need to individually titrate the drugs. Once we feel that the patient is well tolerating and is controlled with this particular combination of drugs, then you can combine them in a single pill. That is how we should practice. But of course, that is practically sometimes very difficult.
So we can conclude, sir. Very nice discussion and points have been taken. And we have
preparations available and being prescribed by doctors,
So,
even cardiologists.
Yes.
5 milligram. 5 milligram is not the appropriate dose.
Absolutely, I agree with you, sir. 10 milligram is the right drug for dapagliflozin.
So we have the GB meeting waiting, and we have 3 more speakers to come. So thank you, sir.
Thank you
very much.
Thank you, sir. The next topic is diabetes and bone connection. Understated about opinions. For this, I would like to invite Dr. Ajay Tiwari, Director and Consultant Diabetologist, Joy Clinic and Diabetes Care Center, Lucknow, Associate Professor of Medicine, HIMS Lucknow, former Assistant Professor, Era Medical College, Lucknow, Secretary, RSSDI, UP Chapter. Over to you, sir.
Thank you, respected chairpersons, and at the onset, I'd like to thank Professor Jayant Panda and the entire team of RSSDI ODISHA for giving me this very interesting topic. And I have put it like this: diabetes and bone fragility, overlooked but obvious, because throughout the day we have been talking about microvascular complications, macrovascular complications, and I think the 75% of the conference time goes to micro and macrovascular complications. So I will, in next 15 to 20 minutes, will make you agree that we are overlooking this very important aspect, and this is very important, and now we are calling it as diabetic bone disease. So to state the magnitude of the problem, I have put in this slide. So we call it as bone attack. It is equivalent to heart attack or the brain attack. So it is something which should not be overlooked, because what I am going to tell you is that hip fracture outcome is really very poor, and it amounts to around 20% in the first year, and by the 5th year the mortality is to the tune of 50%. So this is something which we have to look for, and we have to look for it proactively, and we have to also think about the modalities for prevention of this issue. So osteoporosis due to diabetes mellitus, now we call it as diabetic bone disease. This is a secondary form of osteoporosis. The primary form of osteoporosis is age related, and this is a secondary form of osteoporosis. So what are the factors, risk factors associated with diabetic bone disease? So the insulin therapy and the concomitant hypoglycemia that can lead to falls and fractures. Vascular complications are associated with increased incidence of fractures irrespective of hyperglycemia or the duration of diabetes. The glucose management, so we already know about the J curve, so hyperglycemia, and at the same time, at the other end, the hypoglycemia, both contribute to increased fracture risk in people with diabetes. Diabetes duration correlates with the increased incidence of fractures. We will see why we are, at what time we have to go for the BMD measurements in people with diabetes. Then obesity, it has got both effects. The weight bearing increases the bone, but at the same time, the chronic inflammation leads to increased incidence of fractures. The insulin levels, hyperglycemia, advanced glycation end products, and the bone vasculature. So when we are talking about this, we are talking more about the bone vasculature, because it is the trabecular structure of the bone which is most affected. Even with an increased BMD in people with type 2 diabetes, we have increased incidence of fractures. Then the BMD, the bone mineral density, bone microarchitecture, and the bone turnover, all these factors contribute to the bone disease. So this is basically a broad differentiation between how we have the fractures in people with type 1 diabetes or type 2 diabetes. So the type 1 diabetes obviously is associated with a higher fracture risk as compared to type 2 diabetes. And the most important factor as regards to this particular thing is most striking at the level of the hip. So we are more and more concerned about the fractures at the hip because they give us a very bad prognosis. Then this is a very interesting 9-year cohort study of more than 35,000 patients, and where they find that with people with type 2 diabetes of more than 5 years duration, after adjusting for age, BMI, and daily smoking, the relative risk of having bone fractures was to the tune of around 1.8 times. So that's a huge numbers, and we definitely have to look for these problems proactively. So now coming, does diabetes affect bone? So there is a paradox also, that the diabetes can also affect the diabetes affects the bone, and the bone also has mechanisms which can affect the glycemia. So this is basically, we understand the bone is a very dynamic structure, and if you see a normal bone, the upper one is a normal bone. So this balance of the osteoblastic activity and the osteoclastic activity, that leads to a healthy bone. In type 2 diabetes mellitus, because of the increased glucose or in the hyperinsulinemia state, that is the increased insulin, these particular factors like the RUNX2, Osterix, WNT, BMP2, and OPN, they are decreased. There is increased osteoclastogenesis, and there is a shift from the mesenchymal cells to the adipocyte lines of the growth. So that leads to the weakening of the bone structure. And then there are other factors like the sclerostin, RANKL, and FGF23. They have the bearing on the drugs that we will be discussing in the subsequent studies. So if you see, so this is a broad differentiation between type 1 and type 2 diabetes. So fracture risk, especially hip, is more so in people with type 1 diabetes, and lesser but increased incidence in people with type 2 diabetes also. The bone strength is decreased more so in people with type 1 diabetes as compared to type 1 diabetes. The bone density, so this is something to watch for, because the bone density, the BMD values are increased in people with type 2 diabetes. Still they have increased incidence of fracture. So that I was talking you, that is because of the microstructure, that is the trabecular structure of the bone. So the turnover is decreased more so in people with type 2 diabetes, and the material properties and microarchitecture are altered in the similar way. So now we come to the management of osteoporosis, the same with or without diabetes. So we have studies where they have seen, they have included people with type 2 diabetes. Basically all osteoporosis studies, they had a small subgroup of people with diabetes. So all these things are basically from the broader studies with the subgroup analysis of people with diabetes. So this is a very important statement, and this is a very important paper. This is the Indian Society for Bone and Mineral Research, that is ISBMR position statement for the diagnosis. So this is come from the group of Badada et al. So what they try to do, they try to see these bone abnormalities or the osteoporosis in people of the Indian origin. So this is very interesting, and there are some important insights from this. So usually what we do, we go for an X-ray for the diagnosis of osteoporosis, because BMD, although is a gold standard, but it is not easily available and it is very costly. So we have to understand that this particular, the bone the loss of the bone will, with a conventional radiography, we will be having only when the bone loss is increased to the tune of 30%, then only it will be obvious in a conventional radiography. So that is to be understood. So that's the reason why we call that the DEXA scan is the gold standard, because it picks up the loss of bone mineral density early on in the course of the disease. Then we have those screening methods that what we do at the calcaneum, that is called the qualitative ultrasound. So they also are good screening techniques, but they are not the gold standard for seeing this thing. So the same holds true for the quantitative CT scans. So this is the basically how you see it, the T-scores and the Z score. There are two terms. The T-score stands for the comparison with the, like mostly we are doing in the post-menopausal one, so between 20 to 29 years, a healthy person of 20 to 29 years. So the T-score stands for this, and the Z score, the G score or the Z score that we call it, that is the of the same age. So for pre-menopausal people or the young people, we are going for the G scores, and for the post-menopausal, we are going for the T scores. So these are the values for this. For normal, it is less than 1. For osteopenia or the low bone mass, it is 1.0 to 2.5, and for osteoporosis, it is minus 2.5 or lower, and the severe osteoporosis is like that. But when we are talking about people with diabetes, this BMD we consider less than minus 2.0. So we are understanding that they have a greater risk for the bone fractures. So we take this BMD value for people with diabetes as minus 2.0. Then this BMD doesn't suffice to give us that these people have a risk. Like we have an ASCVD risk, the same is there are risk scores for the assessment of the osteoporosis. So the most commonly used is the FRAX score, that is the fracture risk assessment tool, and these scores like the score, simple calculated osteoporosis risk evaluation, so they do not incorporate the DEXA scans. So they are basically, they can give us some insights in a clinical setting that these patients may be candidates for a DEXA scan for confirmatory diagnosis. So this is the FRAX score. I think it is not being visible. So what we have to understand that the FRAX score doesn't incorporate the diabetes mellitus. So they say there is a column for rheumatoid arthritis. So if a patient is having diabetes mellitus, then you have to tick that rheumatoid arthritis wala, that box is to be ticked, and at the same time we have to mark the BMD cutoff as if it is less than minus 2.0. So that is how we do it, and this is how we initiate pharmacological therapy. So if there is already a vertebral or hip fracture, the T score is less than minus 2.5 at femoral neck or spine, and for people with diabetes it is 2.0. And the FRAX score, the calculated FRAX score, 10-year probability of any major osteoporotic fracture is more than 20%. And we are more concerned about the hip, so it should not be more than 3%. So if it is like that, then we have to initiate the treatment. So what are the basics of the treatment? It's a very wide topic, but we have to understand that we have to give vitamin D and calcium supplementation to all people with osteoporosis. So that's very important, and the management of osteoporosis in the setting of diabetes or without diabetes is the same. Then we have to also talk about the alcohol intake is to be reduced, stop smoking, active lifestyle. We have already shown that if you are having active lifestyle, we are having more of osteoblastic activity. Then very important things are about because usually they are octogenarian patients. So we have to tell them how they have to avoid the falls. So not changing the cloths in the bathroom, using rubber sole footwears, or having lights which open with the sensor. So all these things can help in that. So the Endocrine Society recommendations are to treat higher risk individuals. Biphosphonates are the first therapeutic choice for postmenopausal women at high risk of fracture. Assess the BMD scores on the patients who are already on these things. And if the BMD scores are stabilizing or we are having an optimum increase then we can go for a biphosphonate holiday also. So we can reinitiate after the BMD scores start falling. Consider anabolic therapy. So we have got this recombinant, this PTH, that is therapies other than anabolic therapy should consume calcium and vitamin D in their diet or via supplements. And the BMD has to be monitored every 1 to 3 years. So this is broadly what I discussed, and these are specific recommendations for prevalent vertebral fractures. Teriparatide, which is an anabolic agent, is a drug of choice, or we can go for the intravenous zoledronic acid. For individuals with prevalent hip fractures, intravenous zoledronic acid, which is to be given yearly, is a drug of choice. And now we are having denosumab also. So that is also an anti-resorptive therapy. So we have got anabolic therapies and the anti-resorptive therapies. And for high-risk individuals without prevalent fractures, biphosphonates, denosumab or teriparatide can be given. Then other agents are intranasal calcitonin, estrogens, which is for postmenopausal women, and the testosterone. So these are the other agents, but usually we are going for the biphosphonates. So these are the recommendations. Biphosphonates, some important points about these drugs. So biphosphonates, we have to be careful when we are using these patients in the case of renal impairment. Denosumab has an advantage because it has a good effect on the glycemic control also, but there is an increased risk of non-vertebral fractures in the FREEDOM trial, so we have to be careful when we are using this agent in people with diabetes. Then anabolic therapies, teriparatide associated with greater femoral neck BMD gains and similar reduction in all fractures in those with or without type 2 diabetes, but we have to consider about the cardiovascular safety with romosozumab. Then a word about consider HbA1c targets, as there may be J-curve association between HbA1c and fracture risk. I have already told you hypoglycemia or hyperglycemia again. So these are the basic drugs that are used, and these are the usual doses in which they are given. A word about the anti-diabetic drugs and caution in osteoporosis. So glutazones, because they are shifting from the mesenchymal lines to the adipocyte lines, are a red signal. Sulfonylureas, insulin, because of their increased incidence of hypoglycemia, better to avoid. Canagliflozin, we had in the CANVAS trial, we had for increased fracture risk, so better to avoid. And these drugs, metformin, DP4 inhibitors, and GLP-1 analogs are safe for managing osteoporosis in the setting of diabetes. Lastly, I will be talking about this new drug that is an anti-sclerostin monoclonal antibody. This is romosozumab, and this is from Eli Lilly. And sclerostin is produced in osteocytes. The main function is to inhibit bone formation. So inhibition of bone formation is necessary to ensure that bones are of the correct size. So this sclerostin, so anti-sclerostin monoclonal antibody. So if you see, this is the result. So this is a entirely dilapidated bone structure, and after this particular sclerostin therapy, so this is all improved. So this is a wonderful drug. It's very costly, available. So I'll conclude, diabetes has a strong impact on bone health and skeletal fragility, and is now recognized as a complication of both type 1 and type 2 diabetes mellitus. Fracture risk is greater in patients with type 1 diabetes than type 2 diabetes mellitus, and increases with increasing disease duration. Diabetes bone disease is associated with increased morbidity and mortality, and prevention is the key. So the word is prevention, 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 and being proactive to look for this particular complication of diabetes. So thank you for patient hearing, and I think I was on time.
Thank you, sir. A very nice presentation on diabetes and osteoporosis. Due to paucity of time, we're not taking the questions. Now we'll go for the next session, which is on uncontrolled diabetes and its effect on kidney, heart, and the metabolic effects. So which has been, okay, we'll go to the next topic, which is travel and diabetes. So to discuss on this, we have none other than Dr. Saibal Guha, who is the Director, Positive Health Center, Boring Canal Road, Patna. So, sir, your topic.
Good evening, respected chairperson sirs, and august members of the audience. My sincere thanks to Dr. Jayant Panda sir, the dynamic organizer of this conference, and the organizing team for giving me this opportunity to come over and visit this holy city. I'll be moving slightly off from hard science, what we have been talking about since the morning. I'll be talking about travel and diabetes and how diabetics especially need some precautions while undertaking any travel. Data management, we all know the US is the best at it. So we'll start with the US data that about 25.8 million patients with diabetes live in the US, and about 69% of Americans traveled for leisure last year. And again, about 22% of Americans traveled for business last year. So we can see a humongous number of Americans who had traveled. So that is the US data. We don't have data specific for diabetics in our country, but we have come across the term revenge tourism right from the COVID times. The Collins Dictionary defines it as a period, that tourism that follows a period of being unable to travel. So that happened after COVID. And Indians are moving on to revenge tourism since last few years after COVID. These are the data. This is the publication in Forbes magazine, which shows that more Indians are traveling internationally than before. And this is the Ministry of Immigration data. And we can see how the number of travelers have increased over the years. It has been about 45 lakhs in 2001, and it has increased to 2 crores 16 lakhs in 2022. So a large number of people are traveling. So it's all the more important to know what precautions people should do, especially our diabetic patients should take when they are planning to travel. And as this graph shows that many of us are traveling for leisure, for work, for traveling, visiting their families. So a plethora of different reasons to travel, and we see that travelers consist of all ages. So if you see the age-wise classification, so across all ages, across all reasons, people are traveling. So what should diabetes patients do for travel? Should they travel or not? Yes, why not? Traveling with diabetes means that there are a few more things to think about before one sets off. But yes, we should reassure our patients that just because they are diabetics, they need not, the disease should not be a barrier towards travel. If you see the general precautions one should take, we can classify into the pre-travel preparations, the preparations at the airport, during the travel preparations, and some specific precautions at the destination. If we talk about preparations before departure, it's very important that the patient do some homework before traveling. The first and foremost we should ensure our patient is to tell them to take a proper travel insurance, mentioning thereby that it mentions the pre-existing conditions, because many a times people do travel insurance, but they are refused the insurance claims because they say that you have not declared that you are a diabetic. So that is one important thing. Then they should check the different health information advisories specific for that country, meet the doctor a few weeks before the travel and ask about the concerns, recommendations for that particular country or for his particular disease, call his airline or cruise for any particular special precautions, special meals, and any mechanisms for storage of insulin which they have. Then know the local airport's guidelines for passage or carrying of medicines and consumables. And definitely they should make a medical ID that they are diabetics, that should mention that. Packaging the hand baggage is important, very important. We should always tell our patient that they should have a diabetes identity card or a wristband with them. And all diabetic medications like insulin, syringes, meters, test strips, the pump supplies, they should store in the cabin baggage, preferably in their original wrapper with the prescription labels clearly visible. Travel letter can be used to mention one has diabetes and to mention what medicines he needs to carry. That helps them to carry more than 100 ml, which have been the standard precaution these days for airline travels. Then doctor's prescription should be there in the hand baggage. Preparations for hypoglycemia, if he has that in the during the travel, that should be there, like carrying lozenges or nuts and fruits with them. Then he should preferably split the medicines which he is carrying into 2 hand baggages. One his partner is carrying, he can shift half of the medicines in that baggage. So in case one bag is lost, he is not left without any medicine. And he should have a ready reckoner list with him, which must contain his doctor's contact info, the medications he is taking, and the instructions for what is required to do in case of emergencies. At the airport, this is the usual scenario at all the international airports which we are traveling. Of course, the last line here is a slightly over-exaggeration, but yes, that is a big hassle, and we all know, but we should caution our patients to look up for the manufacturer's advice on flying, especially patients who are on insulin pumps or using CGM or flash glucose sensors. But usually most of them are safe to use in the flight and safe for across the X-ray screening also. They should have a medical device awareness card ready for the Civil Aviation Authority when they are traveling. Most of the CGMs and sensors and pumps are safe for the metal detectors, but some have few cautions for the X-ray scanners. So one should know when he is carrying a gadget with him that what should be done when he needs to pass through the X-ray. The last thing a patient should be told that he should never be asked to remove a medical device from his body if he is on something before screening, and he should rather insist on a PAT screening, a physical screening, instead of an X-ray screening if the need arises. And one should have then organized medications with the healthcare team. One should always have prescriptions for extra medicine, extra insulin, extra oral drugs, and at least 1.5 to 2 times the requirement for his duration of travel he should take. He should get advice on adjusting the insulin dose and insulin pump when he is outside, and keep the copies of the recent prescription in every baggage he is carrying. During the journey, if there are certain issues which has to be kept in mind, like he has less control over meals when he is in the flight or in the cruise, he has less control over his activity levels. Usually one is sedentary, especially on long haul flights, it's a big pain. And acute travel related illness or correcting hypos should be talked about. Medicines or supplies lost or missed, we should explain that before his journey. Insulin storage, how to do, where to do, that should be told. Changing time zones and adjustment of doses accordingly is an important thing which we will talk later on. Retinopathy and altitude is a factor. Diabetic foot needs extra precaution. Altitude effects on certain glucometers and insulin pumps, especially the older generation glucometers, is important to know. And there is increased absorption of insulin if the person stays in a cold area and is going to visit a tropical destination. So absorption of insulin is increased. So that is one more precaution one should know. So he should carry glucose tablets, candies accordingly. He should request meals that are low in sugar and fat. Shouldn't sit for long hours. He should be instructed to stand up, take stretches, and take walks around in the aisle. Should keep himself hydrated, preferably non-alcoholic, caffeine-free beverages should be encouraged. And on long haul flights, he may need snacks in between meals and at bedtime. The airplane cabins are pressurized, so he should, before using the syringe in flight, he should remove and replace the plunger, because sometimes that jams and causes a problem. So, and wristwatch, he should be told to keep it at the time of the departure place, city of departure, and not coincide with the city of destination when he is traveling. And then certain standby medications he can carry along, like which he needs to treat travelers' diarrhea, skin or soft tissue infections, diabetic foot infections, or vaginal candidiasis. So he can carry some of these simple medications. At the destination, there are certain precautions which are specific for the place he is going. If he is traveling to a hot area, hot or humid area like in the tropics, he should wear clothes that cover the skin, use sunscreens, take care of feet if neuropathy is there, especially he should use socks and sunscreens and well-fitting sandals. Then he should check his glucose levels more often. The insulin may get damaged, so he should take usual precautions. Sunbathing can raise the blood sugar levels, or conversely, it can reduce it rapidly because of fast insulin absorption. Extremes of temperature changes the accuracy of glucometers, so that's one more concern one should be cautious about. If he is traveling to the hills or in the cold places, insulin may be absorbed more slowly at first, so initial few days he may be having increased sugar levels as on the same doses of insulin which he has been taking at home. Shivering for staying warm uses of more energy, and hypos are more dangerous in the cold weather as they interfere with the body's attempt to stay warm and increase the risk of hypothermia. and the meter may not be as accurate as at his home when he is visiting in a cold place. And in case of poor circulation or neuropathy, it's important to prevent frostbite. Insulin should not be used if it has been frozen. If he is traveling by road, there are certain precautions he should be told, that the patient should check glucose prior to travel and regularly during the journey, and he should pull over at the first signs of hypos. He should limit himself to 10 to 12 hours of traveling in a day at the most, and there should not be more than 6 hours between meals. So that is the usual precaution one needs to be told, and he should keep his medications, meals and snack timings as regular as possible even during the travel. And he should always carry some meal in his vehicle when he is doing a road travel, so in case of lockdowns or in case of road blockages, he may need so. Diabetes management in travel is a general topic as I started off, but it's not very relevant to patients who are on oral hypoglycemics. But patients who are on insulin, he should be aware of this, especially if he is traveling across 5 or more time zones. It becomes very important for him, because westward travel, the day becomes longer, he requires, the insulin requirement increases. Conversely happens in the eastward travels, and previously the conventional regular plus long acting insulin regimens were being used. Now it's advised that the basal and ultra short acting regimens are the safest and easiest to adjust during travel when he is flying across various time zones. Insulin pumps, CGMs, may need to change the date or time on some of the insulin pumps which are manual. So that is one big precaution one should take. There are certain conventional regimens on adjustment of how to adjust the insulin during the travel. The first is the rule of thirds, which was done when previously when most of the patients were using biphasic twice daily regimen. If he is traveling west and more than 5 time zones across, he should increase the insulin dose, usually increases by 1/3. So what is need to be done is day of departure, like he is departing at midnight flight from say Delhi, he is leaving abroad by midnight flight. So on the day of the departure, he should take his usual morning insulin in the morning. He will be boarding his flight at night. So the PM insulin dose, the nighttime dose, he takes about 10 to 12 hours after the morning dose, and that dose he will take the usual dose on that day. Then after further 6 hours from the nighttime dose, he should start checking his sugar levels randomly, say every 2 hours or 4 hours. And if the morning insulin, like after 6 or 7 hours from the nighttime insulin dose, if the morning level of insulin is more than 200, he can take 1/3 of the morning dose with the snacks, 1/3 of the biphasic insulin dose which he takes in the morning with the snacks. And then when he reaches his place of destination, where the time gap is more than 5 to 6 hours, then he again matches his watch to the destination time and takes his usual morning dose. So he takes a 1/3 of extra morning dose in between the flight if the sugar level is more than 200. The converse happens when he travels east. The evening dose he takes at the day of departure, the morning dose is usual, morning dose is taken, evening dose is taken 10 to 12 hours of dose, and when he reaches his place of destination, the next day, he takes the next morning dose at the time of destination, but it would be 2/3 of the usual dose. So he reduces the next morning dose by 2/3. So that was the usual convention when biphasic twice daily regimen was used. Now most of the patients are on basal, bolus, basal and ultra short acting insulin when they are traveling. So when he is traveling west, more than 5 zones, and he should take half the basal dose on the night of departure at the local time. Like he takes his basal dose in home at 10 PM at night. So he leaves from Delhi tonight at midnight. So he takes the half of the basal dose tonight at midnight. Then he boards his flight. He adjusts his watch from local time to destination time. 2 minutes. He adjusts his watch from local time to destination time, and he takes half the basal dose on the same time as per the discharge time, which may be 5 hours later. So he takes half of the basal dose at 10 PM in Delhi, boards his flight, adjusts his watch to London time. Then when it's 10 PM at London, which is about 5.5 hours later, he takes half the basal dose again. And then when he reaches the next day, he starts taking the full basal dose, the usual basal dose at the London time of 10 PM. The converse happens when he is traveling east, sorry, this should be eastward. The usual morning basal he takes, and this is for twice daily basal regimen. So usual morning basal, half night time basal, then again adjusts watch and does the same. So east-west travel, there is a complicated formula to calculate it, but one may not need that. One should reduce the basal on day of travel by just 10 to 20%, and the next day morning he should check the sugar levels and adjust accordingly. Pre-mixed insulin twice daily, he should take usual insulin before departure. Prior to departure, check his blood sugar every 4 to 6 hours and take correctional doses with a short-acting, rapid-acting insulin if the sugar levels are more than 200, and then follow up with the usual twice daily premixed insulin from the next day onwards. Certain precautions more need to be taken if the patient has neuropathy, retinopathy and nephropathy, which I won't go into details. And this is quite obvious because patient is more prone to develop various complications. So these patients should take extra precautions. So to summarize, we should need to tell our patients to carry adequate supplies of medicines and consumables, preferably for a longer duration than he would need to stay there, and in their original wrappers for the security purpose. He should calculate the travel duration and the time zones prior to his travel and calculate his insulin doses accordingly. He should preferably switch to a basal bolus and a rapid-acting insulin for proper control, or he can continue with the premix with correctional mealtime dosage. And aim is to prevent hypos in transit. Hypers are never a problem. Aim is to prevent hypoglycemias in transit. There is very good website citing travel tips, traveling with diabetes, which is very useful for patients. We can share this with our patients as well. So bon voyage, and thank you for a patient listening.
Thank you, sir, for this very nice presentation. Now come to the last topic of this session, and the topic is uncontrolled diabetes effect on kidney and heart. Focus on the CKM syndrome. Now for this, I would like to invite Dr. Binay Kumar Dhandhania, Secretary RSSDI Jharkhand State, Chairman-elect RSSDI Jharkhand. Over to you, sir.
Thank you, chairpersons, for that very kind introduction. Good evening, respected seniors, dear friends. At the onset, I would like to thank the organizers, especially Dr. Jayant Panda, for inviting me to this holy place. And I acknowledge each and every one of you for being here till the end of this meeting. I'm going to talk on uncontrolled diabetes effect on kidney and heart, focus on CKM syndrome. I'm sure you all must have heard a lot of lectures regarding kidney and heart and metabolic syndromes and all these things together. But believe me, this is going to be a totally different presentation. You must have heard recently talked very well presented by Dr. Arun Kedia, who is sitting right in front of me. But this is a totally different presentation, and you will have a really good take-home message after this presentation. So CKM syndrome is a systemic disorder characterized by pathophysiological interaction among metabolic risk factors, CKD and cardiovascular system. I can tell you a very simple way to understand. Diabetes is a heart disease equivalent, CSD equivalent. Similarly, CKD is also a CAD equivalent. So when both of them are coexisting, diabetes and CKD, you can imagine the probable incidence of CAD in this group of patients. So if you prevent both, you can prevent a lot of complications ongoing in a diabetic patient. So the need for emphasis on CKM is because it causes premature mortality, multi-organ disease, excess morbidity, and high health cost. Because CKD patients will have peripheral neuropathy, will have retinopathy, will have a risk for heart failure, and as you heard, the bone disease, you all know that CKD affects the bone. So it's a complex mechanism, and it increases the burden of any patient coming to your clinic. And the cost of therapy is phenomenal. See the prescription of a patient with diabetes and CKD. They are on 2 to 3 medicines for diabetes, 3 or 4 medicines for hypertension, statins. Then you have these PPIs and whatnot. There is a big list of medicines for these patients, insulin, and they need to carry also insulin. So risk enhancing factors for CKM syndromes is basically chronic inflammatory conditions, high risk demographic groups, mental health disorders. I practice in an area where we have a Central Institute of Psychiatry, and there are a lot of patients who are having bipolar disorders, chronic depression, and chronic psychotic disease, and they are on, again on 5 or 6 antipsychotic medications. Very difficult to manage when you write 3-4 medications from your part as well. Sleep disorders, especially obstructive sleep apnea, is again a very big problem, and it's a real tip of the iceberg which we see today. We need to ask patients. Patient will tell you, डॉक्टर साहब रात को नींद नहीं आता है, मैं दिन भर सोता रहता हूँ, and you know what, the whole night they keep doing exercise of taking snoring. I mean, snoring is what, an exercise. The whole night they are doing exercise. So how they can be relaxed early in the morning? Something went wrong, I think. Oops. Boss, the slide is changing automatically. I'm not doing anything. I think it's garam ho gaya, thanda hona chahiye. Ab sure? नहीं, अपने आप चेंज हो रहा है, अपने आप चेंज हो रहा है. मैं फिर से ट्राई करूं? नहीं, अपने आप चेंज हो जा रहा है. Yeah, and as you all know that multidisciplinary approach is very, very important. You need to have a nephrologist on board, diabetologist or an endocrinologist, and a cardiologist. All three are actually very, very important in managing this category of patients. We have different stages of metabolic disorders for CKM patients: metabolic syndrome, hypertriglyceridemia, and hypertension, and all needs to be very, very intensively managed. We heard Dr. Rakesh Saha in the morning, and he said very, very important things, that you need to tell your patients that these are the important risk factors and you need to treat them individually at a very intensively. So this is very, very important message, that you need to treat metabolic syndrome. Weight reduction is important, hypertriglyceridemia is important, hypertension management is important, and believe me, hypertension management is the most difficult management. People tend to stop medications. Evening readings are different, the morning readings are different, and they are on multiple drugs. Usually a diabetic hypertensive requires 3 or more antihypertensive drugs. Management again is achieving a good lifestyle, HbA1c reduction, lipid lowering is needed, antihypertensives are needed, and for stage 1 to 3, a promotion of cardiovascular health is very, very important. Systematic screening of systematic disease of health using validated tools, if you have in your clinics, is also very, very important in the community. These are the different stages: excess or dysfunctional adiposity. Then stage 2 is presence of metabolic syndrome, which triggers intensive lifestyle. Not to forget the liver today in metabolic syndrome. Almost all the patients of metabolic syndrome can have NASH or NAFLD, which is again a very important independent risk factor for a heart disease. Most of the NAFLD patients, they die of cardiovascular disease, not because of the chronic liver disease. So that is again one area which needs to be addressed to your patients. Then subclinical cardiovascular disease in CKM syndrome is always there. We need to share this with your patient, that this could be reversible if you treat them well. So algorithm of management of patients with CKM syndrome stage 4 is promotion of again cardiovascular health, systemic screening, interdisciplinary care, and for heart failure you have guideline directed medical therapy for all patients. For atherosclerotic cardiovascular disease, aspirin and high intensity statin for all patients. Consider addition of ezetimibe and PCSK9 inhibitors based on LDL level goals, or even presence of high risk atherosclerotic cardiovascular disease. SGLT2 inhibitors, you all have heard a lot about it. Pleiotropic effects of SGLT2 inhibitors is on heart. There are different mechanisms. Dapagliflozin, again type 2 diabetes and CVD. Here you can see the benefits as far as HbA1c reduction, fasting plasma glucose reduction, body weight reduction, and systolic blood pressure reduction. So you have a lot of benefits with this class of drugs at one time. So whenever you are adding this class of drugs and patient is already on antihypertensive drugs, you should actually ask these people to monitor their blood pressure. Sometimes you need to actually reduce the dose of antihypertensive drugs. DECLARE TB trial was one of the very important landmark cardiovascular outcome trial, and the best part of this trial was they included patients who had multiple risk factors but didn't have an established atherosclerotic cardiovascular disease, and almost 60% of the patients were on primary prevention population. So this was one study of SGLT2 inhibitors which included as a primary prevention population, and 40% patients had secondary prevention population. And the benefits, if you see the primary endpoints, there was a reduction in hospitalization because of heart failure and CVD. 3-point MACE was not that significant because if you club the data separately, if you see the data, you will find that there was a benefits in patients who are on secondary prevention. But if you join both the arms, like for primary prevention and secondary prevention, the 3-point MACE was a narrow curve. So dapagliflozin resulted in lower rate of cardiovascular death or hospitalization because of heart failure. It reduces the risk of hospitalization because of heart failure by 27%, and other cardiovascular trial outcomes, if you see that DAPA-HF trial is again a very landmark study in patients with heart failure and HFrEF patients who received dapagliflozin. So these are the protective effects of SGLT2 inhibitors. Dr. Arun Kedia has discussed about it, so I can take the liberty of skipping this slide. Dapagliflozin in diabetic and non-diabetic chronic kidney disease. Again, DAPA-CKD trial is a landmark study where dapagliflozin reduces the risk of major adverse kidney and cardiovascular events and all-cause mortality in patients with diabetic and non-diabetic chronic kidney disease. Today, stage 3 CKD is definitely an indication for dapagliflozin. Even patients, if they are using ARBs or ACE inhibitors, you should add this class of drugs. But patients should be on ACE inhibitors and ARB. It's not a replacement of ACE inhibitors or ARBs. Some people actually try to stop or don't give ACE inhibitors or ARBs for the risk of hyperkalemia, which is associated with this. But you should try to use first ACE inhibitors and ARBs and then add SGLT2 inhibitors, because most of the studies which they have included ACE inhibitors and ARBs first, and then SGLT2 inhibitors has been added on board. So dapagliflozin in even metabolic syndrome, this is again very interesting data where it suggests that I'm sorry, dapagliflozin plus metformin, more meaningful improvement in any of the component of metabolic syndrome. So if you see a patient for the first time in your clinic and you have hypertriglyceridemia, fatty liver, raised enzymes, SGOT, SGPT, diabetes, hypertension, obesity, or simple circumference which is high, family history which is there with a premature heart disease, this is a class of drugs which you should start using from day one, because now we have even data in non-diabetic patients as well. So even a pre-diabetic obese metabolic syndrome, you can use this class of drugs along with metformin, and I'm sure they will be benefited, and the days are not behind where we'll start getting the data also. Dapagliflozin and changes in metabolic syndrome in patients with type 2 diabetes, a DECLARE TB 58 sub-analysis. So this is what I was talking, that this presentation is going to be a little different. So in patients treated with DAPA, there were lower rates of metabolic syndrome, higher rates of regression, and fewer cases of new metabolic syndrome. And this was driven by favorable effects on blood pressure, weight, BMI, and prevalence of low HDL. And these differences were evident at 6 months and persisted through 48 months. So now DPP-4 inhibitors, we have been listening for decades now. This is how the mechanism of action, the incretin effects, the hormones GIP and GLP are being inhibited by DPP-4 inhibitors, and that is how it actually stimulates the release of insulin from the beta cells in a physiological manner. This is the TCOS study which was published way back in I think 2015, it was published in NEJM, and this was the study design where the cardiovascular outcome was defined as the first confirmed event of cardiovascular death, non-fatal MI, non-fatal stroke or hospitalization because of unstable angina. Primary composite CV outcome was basically that sitagliptin was non-inferior to placebo for the primary composite cardiovascular outcome, and this was most important take home from this particular study, the rate of hospitalization of heart failure did not differ. This was to actually differentiate from saxagliptin, where they are seeing that the rate of hospitalization because of heart failure was higher in the saxagliptin group. The incidence of severe hypoglycemia did not differ between CETA and placebo treatment group. So combined DPP-4 and SGLT2, we see a lot of complementary mechanism of action of DPP-4 and SGLT2 inhibitors. The most important advantage being the chances of euglycemic diabetic ketoacidosis, which is seen with SGLT2 inhibitors, is somehow neutralized with this combination of drugs. And at the same time, the chances of genital urinary tract infection is less with this combination, and they are complementary to each other. And the chances of even hypoglycemia is very, very minimal with this class of drugs, even when added to metformin. So you get a robust reduction of HbA1c, multiple benefits, pleiotropic benefits, and least possible chance of hypoglycemia, additional benefits of weight reduction, additional benefits of blood pressure control, and even care of metabolic syndrome. So there are a lot of evidence with this class of drugs, which we have already heard. So to summarize, 24-week study with 24-week extension period showed OD treatment with DAPA in dual combination with CETA or in triple combination with metformin was well tolerated, led to clinically meaningful reduction in glycemic parameters. Body weight reduction and HbA1c were sustained through 48 weeks of treatment. And the fixed dose combination again has a very, just one more slide, sir. So the results for HbA1c reduction is again very, very robust with the triple drug combination, and most of the patients could achieve the HbA1c target of less than 7% with this class of drugs with the triple drug. And this is one triple drug which has been approved by even the US FDA. The combination of SGLT2 inhibitors, DPP-4 and metformin, a fixed dose combination is also been approved by the US FDA. So the triple drug fixed FDC of DAPA, CETA, metformin tablet once daily leads to better HbA1c reduction and greater proportion of patients achieving HbA1c less than 7% in comparison to dual therapies, and this glycemic control was achieved without any increased risk of hypoglycemia and weight gain. The concept of CKM reflects the strong interrelationship among metabolic risk factors, CKD, and cardiovascular system. CKM at various stages may have significant implications for adverse clinical outcomes, and DAPA and SGLT2 inhibitors and CETA are important drugs with clinical evidence on the management of CKM. So I thank you all for your patient listening, and I thank all the organizers for this opportunity. Thank you very much.
Thank you, sir. Thank you very much. This session was probably the best. We had 5 doyens who spoke on various issues and diabetes, and with this, we are forced to conclude this session because the meeting is already on the way. Please stay back for the mementos.
I request our speakers and chairpersons to please kindly come up on the stage for the felicitation. The GBM has started in the Hall B, first floor. Anyone who is a member of RSSDI Odisha, kindly proceed to Hall B for the GBM.